Hi, folks. If you're just joining us, a reminder to please update your name. The instructions on how to do that are on the slide here. Currently, you are coming in by default listed as Long-Term Care Facility Access Policy Workgroup panelist, which will be quite a mouthful for me to call on if you've raised your hand. And not necessarily very helpful in distinguishing folks on this group. All right, we're coming right up at 12:30. And so we will go ahead and move this meeting into the public space. I know workgroup members are still joining. We will kind of get started and walk through some of the intro slides here today. As a reminder, just before we get started, a number of you who have just joined will notice that you have come into this session labeled as a long-term care facility policy workgroup panelist as your name in Zoom. We ask that you please change that to your actual name so that we can call on you when you raise your hand and things like that during today's meeting. And with that, if we go to the next slide, we can go ahead and kick off today. Hello and welcome to meeting 4 of the California Long-Term Care Facility Access Policy Workgroup. This is the last meeting of this workgroup today. My name is Juliette Mullen. I am a senior manager with Manat Health, supporting the California Department of Aging in the facilitation of this workgroup, and I'll be kicking us off today with a few housekeeping items. Throughout the meeting, the CDA communications team will be in the background answering any Zoom technical questions. So please feel free to drop those in the chat at any point in time if you experience issues. The chat panel is also available throughout today's session for comments and feedback. We'll provide additional information on that shortly. During today's event, live closed captioning will be available. We are also joined by American Sign Language interpreters who will be providing live translation throughout today's meeting. We can go to the next slide, please. All right, before we kick off, we want to remind everyone of the purpose of this work group and what this meeting is today to make sure everyone is in the right place. Commissioned by the California Department of Legislature, by the California Legislature, the Long-Term Care Facility Access Policy Workgroup will develop recommendations for policies and practices regarding access and visitation to long-term care facilities during states of emergency, with consideration for the impact that restricted access has on the mental health of residents, families, and friends, and on the physical health and safety of residents. This is meeting number 4 of this work group. Next slide, please. Just as a reminder, California and the California Department of Aging are committed to ensuring an open, transparent, and accessible process for this work group. All workgroup meetings are being held publicly and are subject to the Bagley-Keene Open Meeting Act. All meetings and deliberations of this workgroup will be made available to the public, and members of the public will have an opportunity to provide comments at every meeting. Meeting information, agendas, and materials from past workgroup meetings will be available on the following webpage, and we'll drop a link to that in the chat as well, hoping that our workgroup members today are familiar with that. Moving into how to participate in today's session, workgroup members will be fairly familiar with this, so I'll go quickly. Throughout the session today, we will have long stretches of opportunity to provide verbal comment, and members of the workgroup will be able to do so by raising their hands in the reaction feature of Zoom to enter the line for a verbal comment or question. In addition to that, workgroup members are encouraged to submit comments and questions throughout the meeting using the Zoom chat. We will do our best to respond to those throughout the session. Sometimes the volume is such that it's a bit difficult to respond to everything all at once, but everything will be recorded and reviewed by CDA staff and the facilitation team. Workgroup members should send their comments to everyone every time that you're in the chat so that members of the public can also see your comments. If you send them to hosts and panelists only workgroup members will be able to see those, and we want to make sure everyone can see any comments in the chat. So please be sure to set those to everyone. And finally, one note here, as we did in our last meeting and meeting number 3, there will be periods throughout the session today where we will ask workgroup members to react to put proposed edits to the recommendations, and we will do that using Poll Everywhere surveys throughout the meeting. So we'll provide a little more information on that when the time comes. Next slide, please. Finally, also want to share for members of the public what the process and the logistics will be for participating during today's session as well. Members of the public will be invited at several points throughout today's session to provide public comment and response to the deliberations of the work group. At that time, we'll encourage members of the public to raise their hand in the reaction feature of Zoom or to press *9 on their dial phone pad if they've joined by phone. At that point, we will invite members of the public to take themselves off mute and provide their comment. In addition, members of the public will have access to the Q&A throughout today's conversation and are welcomed and encouraged to put comments and questions there. As with the chat, sometimes the volume becomes such that we can't respond to everything live during the session, but everything will be recorded and reviewed by CDA staff. Next slide, please. And with that, I'm going to hand it over to Brandi Duvall with the California Department of Aging. Brandi.
Thank you. Well, welcome again to the Long-Term Care Facility Access Workgroup, meeting number 4. My name is Brandi Duvall, and I am an attorney at CDA. As this workgroup begins its last meeting, I would like to say thank you to the workgroup members and the members of the public for all of your heartfelt and lively engagement on this work and for joining today's meeting. Let's begin by taking a look at the agenda for today. We will start by recapping some background on the workgroup's tasks, previous workgroup meetings, and output of the workgroup. Then we will kick off the first part of the discussion on policy and practice recommendations. We will do that by discussing recommendations A to C, which have been revised twice since the last meeting based on workgroup feedback. For each recommendation, we will summarize feedback provided on the recommendations by the workgroup and the public. We will review the latest proposal, which reflects that feedback, and we will discuss any final changes the workgroup wants to make to the recommendation. Then we take a break for 20 minutes. After the break, we will continue the discussion with recommendations D through F. We will take public comment at specific points throughout the discussion today. Next slide, please. I would like to take the time to introduce my colleagues. You already met Juliet Mullen, Senior Manager for Manat Health, and of course, Mr. Mark Beckley, Chief Deputy Director here at CDA. On this slide, we have our workgroup members. This shows the organizations and their representatives that are participating in this workgroup. As a reminder, we've posted a list of all of the representatives and their biographies on the CDA website. A member of our team will drop a link to that in the chat now. We've also included some bios which have been submitted to CDA. At this time, I'd like to invite representatives from these organizations to say hello, to drop some comments into the chat, providing their name, title, and organization. And I think I saw that Mately had already started us off, but great. Thank you, Derek. I see your names coming up now. I'll just pause for a second. That's okay, Mately. Great. So while those are coming in, I will pass it over to Mark Beckley. Thank you.
Great. Thank you so much, Brandi. Oh, sorry, there's a little bit of an echo in the room. It is. Oh.
Okay, sorry for the technical difficulties, everybody. I think I have that resolved. So I'd like to thank everybody again, echoing what Brandi said, for participating in this committee. It's been a long journey over the past 6 months. I really appreciate everybody's active participation, your comments, both within the meeting and then between the meetings as we've sent out surveys and asked for additional input from you. This has really made this a very productive process, a very constructive process, and just so appreciate all the time and effort that all of you have dedicated to this work group. Before we get into discussing the revised recommendations, and that will be the focus of this meeting and where the majority of our time will be spent, I'd like to take a minute to remind ourselves of what this work group has been tasked to do and what we have accomplished over the past 6 months. Next slide. So as many of on this work group will remember, the California legislature began working on policies for long-term care visitation in 2022. And specifically, there was a bill that was introduced that was later put on suspense around visitation policies for long-term care facilities. During this process, the legislature determined that a collaborative working group process was really needed to understand the perspectives of different stakeholders and the policies that key stakeholders could jointly support. As such, they commissioned this work group consisting of long-term care facility residents, advocates, loved ones, public health representatives, long-term care facility operators, and state departments to really work on answering that question. This work group has been tasked specifically to develop recommendations regarding best policies and practices for long-term care facilities during public health emergencies, including but not limited to visitation policies. Ideally, these recommendations should be jointly supported by all of the 3 stakeholder groups that I've mentioned here, but we'll talk a little bit later about how we'll address areas of disagreement. Given that today is our last scheduled meeting, we want to reflect the input from each of these groups in the report to reflect the work group's work. And we may deliberately ask representatives from each of the stakeholder groups to weigh in periodically during today's meeting. Next slide. A number of work group members have asked for more details on what the final output of this work group is going to look like. So I'd like to talk about that now. What CDA will be developing in assistance with MNAT is what we call a recommendations report. This report will summarize the recommendations of this work group, as well as the discussions and area that the work group was not able to fully agree with and align on. That report will be submitted to the appropriate legislative committees. And the recommendation report is really intended to help the legislature understand where there's broad alignment and stakeholder agreement on certain issues regarding visitation and access during public health emergencies, as well as other emergencies. And this report will then help inform any future legislation that the legislature may want to consider on this issue. Okay, next slide. The recommendation report will contain 3 key elements: background, principles, and policy and practice recommendations. So as we look across these 3 sectors, we see that we've got background, which details the work group's discussion and comments, including areas that the work group considered but did not have alignment. Principles that reflect alignment in the work group on important concepts related to long-term care facility access visitation that the work group jointly seeks to convey to the legislature. And then finally, policy and practice recommendations, providing specific recommendations for the legislature to consider in legislative action around long-term care facility access. We have circulated the report in various forms or sections of the report to this work group. So the final deliverable will be sent to you that contains all of the policy, principle, and practice recommendations. And we will be receiving comments on that draft report. Okay, next slide. So with all of this detail regarding the work group output in mind, let's take a moment to briefly recall the key discussions of this work group today. So in meeting one, the work group reviewed research on long-term care facility visitation and access policies. And members of the work group and the public generously shared their lived experiences with long-term care facility visitation. And again, I really just want to thank those members who so courageously and openly shared their experiences. I believe that was very important to this discussion. So this provided an important foundation for the importance of the work and the key areas that this work group has been addressing in its discussions. In this meeting, we also reviewed a summary of legislative approaches to long-term care facility visitation in other states. In meeting two, we discussed 8 actionable principles related to long-term care facility visitation based on the discussion in meeting 3. In our last meeting, we outlined 6 key recommendations for the work group to consider, which built on the principles and were developed based on the discussion in meeting 2. In order to gather feedback on more specific recommendations and language, then we're able to cover during the course of the meetings. Stakeholder input and feedback was also gathered between the meetings through 3 surveys that were sent out by us. We really want to thank everybody for their participation in these surveys. We know that it took a lot of time for you to review the questions, to maybe meet with representatives from your organizations, and to write out your feedbacks and submit them to us. And I also appreciate that some of this was done under fairly tight timeframes, but based on the schedule that we had to complete the work, it was unfortunately necessary. But these have proved invaluable to refining our recommendations. As we discuss each recommendation in the next section, we will articulate how feedback provided by the work group was integrated and reflected in each round of updates, and how the recommendations were refined. We will then ask work group members to provide specific edits that would be needed for them to support the recommendation. And I think this point is really critical. We really hope to send forward to the legislature areas of alignment, recommendations, and key areas of disagreement. But we really hope that by the end of today, we will have some recommendations that hopefully everyone can support, that will assist the legislature in possibly developing additional legislation. So I really encourage all of you to speak up, to speak candidly and honestly, and at the same time, we'll continue to maintain a respectful atmosphere among all stakeholder groups. But unless we really know what the pain or pressure points are and where there might be area for compromise, it'll be hard to really develop really strong and clear recommendations to go forward to the legislature. So as we continue in the course of this discussion, we will be seeking edits from you via a whole everywhere function that the NAP will be posting, indicating where the group may be comfortable with proposed edits. And acknowledging that this is our last meeting, like I say, we may be prompting some of you for to really highlight your area of disagreement or discomfort. So we may be calling on you directly. But please feel free, like I say, to provide your input either verbally or through the chat function. And with that, I will turn it over to Julia. Thank you.
All right, thank you so much, Mark and Brandi. And with that, we're going to move into our first policy and practice recommendation section. Just before we do that, I do want to do one final reminder to folks to please update your name in Zoom. It's going to make it a lot easier when we get to raising our hands and calling on people so I can see folks' names. If you joined as a panelist, your name is currently policy workgroup panelist. And so if you can go in and click rename and put your actual name in there, that would be very helpful. All right, we can go to the next slide. So a couple things that are woven throughout the recommendations that we want to highlight before we dive in. The first is we want to really emphasize that all of what we're about to talk about today reflects recommendations for long-term care visitation during states of emergency in which a local or state order may curtail visitation due to a legitimate public health or safety risk. So we're really emphasizing this particular element and the fact that it's going to be woven through everything today. Because we've gotten this feedback from a number of you all about being really specific about the scenario that we're talking about. This is not a generic set of recommendations for what should happen in any emergency or in any circumstance. It is specifically about this circumstance. So we have endeavored to be very specific in the language on each slide, that is what we are referring to. If I sometimes use the term state of emergency generally, just to move through conversation, I am referring to this context and this type of state of emergency. Just another reminder for folks that we are talking about visitation in long-term care facilities defined as follows on the slide. They include skilled nursing facilities, intermediate care facilities, adult residential facilities, and residential care facilities for the elderly. And so we're highlighting that as we get later into the conversation. We want to think about some of the unique differences between them and how we make sure we account for those in the recommendations. Next slide, please. All right. So with that, we're going to dive into recommendation A. We're hoping to move through this one fairly quickly because we've spent a lot of time in this work group on this recommendation. And this is related to who can visit during an emergency. So if we go to the next slide. So as Mark noted, recommendations have evolved over time. On this recommendation, we have done 3 different versions of this recommendation. I'm going to summarize briefly how this recommendation has evolved and what the core feedback you all have provided over the course of the past few meetings and via surveys has been at a high level. So between version 1, which we discussed in meeting 3, and version 2, you all provided feedback both in meeting 3 and via a follow-up comment opportunity about ways that you wanted to see version 1 change. So between version 1 and version 2, here are some of the core areas of feedback that we endeavored to weave into the recommendation. The first was that version 1 needed to further develop and distinguish between visitor types. And as a result, additional categories were developed for version 2 that reflect the range of visitors who may visit during an emergency and really distinctly call out the different categories without blending them together. The second core area that we received feedback on in version 1 was the workgroup provided feedback to simplify the language on how to designate a visitor. So that was reflected in version 2. And then the last piece we'll call out is based on the feedback on version 1, there was kind of a range in the work group on whether to use the term visitor or support person to describe the individual with designated access. So if we go to the next slide, we sent out a version 2 update to you all via email between meeting 3 and this meeting today. And you all provided additional feedback on version 2 that we have used to again update the recommendations for version 3 that we're going to talk about today. 2 major areas of feedback that we received. The first is we really received strong feedback on version 2 that the term resident designated visitor that was used in version 2 did not adequately reflect the role of the designated individual in supporting that resident's well-being and participating in that resident's care. And so we received strong feedback on version 2 to change the use of the term to resident designated support person. The second major area of feedback on version 2 is we did have workgroup members express concern about the operational challenges associated with having any kind of prescriptive format or process that facilities would be required to follow to designate visitors and track those designations. And this was specifically acknowledging that the recommendation specifically said there would be no limit on the number of people you could designate. And with that in mind, it would therefore be hard to track an unlimited number of designees. And so if we go to the next slide, we have updated proposal A. And so you are now looking at proposed version 3 of recommendation A. So the key areas that changed between version 2 and version 3 are all in orange. So you can really see what the difference has been and how we incorporated feedback. There are really 2 big areas that I'll spotlight. The first is we did update the language from resident designated visitor to resident designated support person, and that edit has been carried throughout all of the recommendations. We also added a very specific clause saying that this recommendation is not intended to require a specific type of process for tracking designation. What it's intended to do is emphasize resident choice. So the core element here is that the resident is the individual that determines who can visit them for that category A of visitor. So I'm going to give people just 30 seconds to read through this. All right, I think that's given folks a moment to read. If we could go to the next slide, I'm just going to kind of illustrate how we'd like to facilitate this conversation, and then we'll go to the line. So what we're hoping to do today is really focus in on areas that the work group really strongly feels need to be edited prior to finalizing this report. So what we're going to encourage people to do is, if you have minor wordsmiths, we're going to encourage people to drop those in the chat so that we can really focus in on where we have really sticky points that we need to address as a work group and we need to kind of do some quick alignment on in the work group. So what we'll do is we're asking people to raise their hand and provide a specific edit to version 3 of this recommendation. So we're asking people to come with a suggested specific change. And then we'll have a brief conversation about that change, and then we may invite folks to actually give us a pulse check on whether they would like to see that edit incorporated and whether they'd be comfortable with seeing that edit potentially incorporated into the final report or not. So with that framing in mind, let's just go back to the recommendation slide so that we can all see it on the screen while we're talking. Thank you. And I see we have folks that have raised their hand. So I'm going to go to the top of the line. We have Catherine Blakemore. Catherine.
So thank you. I appreciate the change in the terminology. I wonder if there is room for saying what a support person is. I didn't have a definition. I thought what you said, how you defined it, Julia, was fine, but because it's not a term that's used now, I think it opens up for interpretation of what that might be. I think people understand visitor could be anyone, but I think support person will have different meanings to different people, different facilities, and unless we use a broad definition like you just gave, it will make it hard for consistency across the state.
I think we have some language from past iterations as we got to this recommendation that we can weave in to kind of define more clearly in the report what that would look like. Thank you. Appreciate that comment. All right. Heather.
Hi, thanks. Appreciate all of the clarifications and additions to this section. My question is with the 4 that's been added. If there are unlimited, and we support this concept, obviously 100%, ensuring ongoing visitation, even in a state of emergency, is a top priority for the assisted living providers that we represent. Just want to be sure the operationalizing it is as smooth and barrier-free as possible. Yeah. The concern that we have is since residents have this choice, which is exactly what we all want, they can change their, they have the right to be visited by whoever they want when that needs to happen. But how does the provider track all that when it's an unlimited number and it can change at any time? I mean, whoever shows up can visit the resident. We don't have to maintain a running list. If I have 80 residents, all the people they want to come see them, tracking that if they can being changed at any time almost seems like a barrier without a purpose. It's just more hurdles people have to go through and the provider has to go through, when the point is residents can see who they want.
Mhm.
Or am I misinterpreting this, or is there another way people are seeing how this would work in practice?
So I think the core I think your point is completely heard. I think the core concept is in having some way to know who to let in the front door, basically. That doesn't necessarily, there's not a specific process that this recommendation is intended to recommend for tracking that. But to indicate that if a resident has said to the facility, I want Heather to be able to visit me, that the facility is going to let Heather in the door. Whether that look like a designation happening in the moment or a designation that's tracked, this recommendation is kind of silent on. Does that help answer your question or give you a thought on a way you might suggest editing this?
I will think about ways to edit it. It just gets challenging in real time. Somebody shows up, they're not on the list, but the resident can designate them at any time. It just becomes a kind of more hurdles, as opposed to letting people come in and visit their loved ones. Then we have to have a check, are you on the list? You're not on the list. Go make a phone call, you can get on the list, instead of just do people have access to visitors? Or are we setting up unnecessary restrictions on visitors? I guess it's another way to look at it.
Yeah. And I think so I'm actually going to read Melody's comment right now. The list would only be needed during a lockdown, not for general operations. So I do think maybe the important context is what's above, that this only applies in a situation where an order has been placed limiting visitation in any way, that there then is a process for tracking who is allowed in the door because they've been designated. This doesn't apply in a situation where there's not an order limiting visitation.
Got it. So there is a limit on visitors. This is contemplating some kind of limit.
This is contemplating a scenario where there is a state of emergency in which there has been a local or state order that in some way curtails visitation. This would indicate that residents have the right to designate individuals and the right to see at least one of them at a time, even in a situation
Okay, so I
where
think
there's a
maybe
limitation.
it's number 2 then, that the facilities may not limit the number of individuals, but the state might be limiting the number of individuals. Is that the issue?
Potentially in this scenario, yes.
Okay, got it.
This recommendation is saying that a local or state order should not curtail it must at least meet the minimum where a resident can have at least one person at a time.
Okay, I got it. And I wanted to also respond to Nancy's comment. We absolutely do not see our residents as an inconvenience. We're trying to make this as convenient as possible for our residents, so that they can continue to have a free flow of visitors during these difficult times.
Appreciate that comment, Heather. And I think this really gets to the concept of when there is curtailed visitation, how does the facility know who to let in the door?
Got it. Thank you.
And I'm glad we had this conversation. I think that helped clarify some of it. But if you want to pause and think about maybe an additional edit to clarify that, we'll welcome that.
Got it. Thanks.
When it comes to you. Yeah, great. Thank you. All right. I see Beth has raised her hand.
Hi, thank you. I'm with CalVet, the California Department of Veterans Affairs, and we run the veterans homes throughout the state of California, which are skilled nursing and assisted living facilities for veterans and some spouses. My question's kind of along the same lines. Part of it was answered by that earlier conversation, so thank you very much to you all and to the representative from Cala. But there's maybe another part of it that I just want to clarify. And I know we went over some of this in the prior meeting, so I'm sorry for any repetition, but I just want to make sure it's clear in my mind. So, Yes, so in our facilities during the height of the pandemic, we did outdoor visitation, even long before we were able to bring back indoor normal visitation in rooms and things. We had outdoor visitation with setups with, a barrier and chairs and whatnot. And then we also did tablets a lot, for FaceTime and things like that. And so that was one way that we were able to keep people in touch. So when it comes to this, though, if there is, for example, a local county public health, directive that we need to strictly curtail certain kinds of gatherings and activities and things like that, is this something, and I fully support the concept here. So I just want to make sure that it's clear. Is this something that could then be applied? I mean, either as it was suggested just now, to some extent, this would be able to override, in a way, for lack of a better term, that directive, not override it, but be added in, factored in as we manage that and comply with that. But also, so I guess my question is, if we do get something that's clear cut from the county, for example, how do we balance these? And then is outdoor visitation maybe a way that we would balance this? I'm just trying to think operationally. If we have this recommendation, then let's say it goes somewhere, with legislation or whatever, and then we also have a county directive. How do we, I fully support this, but how do we balance that operationally?
Yeah, I really appreciate that question. So we're going to have kind of a whole recommendation that focuses on what visitation looks like, and with acknowledgement for that point, Beth, of there may be situations where visitation parameters vary somewhat in different states of emergency. And so we'll look at that as we get a little bit further. I think what's core here, and I know we have some folks that may have some comments on this in line as well, but what's core here is the idea here is that the local or state order itself would acknowledge that this visitation can continue.
This would be full in. Okay, good. That's what I assumed, and I just wanted to make sure, because as we're achieving all these different things, we'd have to be able to combine them. Okay.
Right. The intent is not to create contradictory.
Right. And the intent on our part is to allow, visitation and these, perpetuating these very important ongoing relationships between residents and family and friends and things as much as we can. So I appreciate the thought that went into this recommendation.
Thank you, Beth. Appreciate that. All right, Anissa, I see you've raised your hand.
Hi, thank you. So I'm Anissa Davis. I'm the president of the California Conference of Local Health Officers. And I just wanted to provide feedback. We also are very much in support in concept of the resident designated support people. We feel like they are very instrumental in the health and well-being of residents in long-term care facilities. The issue is that we have to be able to have the tools that we need to address the situation that presents itself. And so it's really difficult to have any kind of limitations placed on that ability. Like, it's just really difficult to say that there's not ever going to be a situation in the future that's significant public health risk or safety risk where we may, for the benefit of the entire facility, have to limit visitation more than what's stated here. And so by having these restrictions placed, it's really limiting our ability to respond to a public health emergency adequately in a long-term care facility. So we,
Oh, go ahead. No, please finish.
I was going to say, so we agree with the importance, and we don't feel that there should be a curtailing of state and local orders.
And can I just ask a follow-up there? So in our its recommendations C and D, when we get to them, they have kind of clauses in them that acknowledge what you're speaking to, Anissa, which is we can't anticipate every situation today in this moment. And so in those situations, there is a process through which the state can establish transparent, public, collaborative recommendations in a timely and fast way. And so that is acknowledged in recommendations C and D in terms of defining the safety protocols and the parameters for visitation. Knowing that those elements are there in C and D, is there something in this that would need editing in your mind? Acknowledging that there is those provisions coming up in C and D.
Right. So C and D, it felt a little different. It felt like you've made a decision and now we're going to do something after that. Whereas this is something that's saying when you're making the decision, there's some parameters on the decision. So to me, this is about making the decision. And I think we need to be able to have all the tools that we need. And there's just no way that we can be able to say that there's never going to be a time when we may need to limit visitation more than what's right here in this this recommendation A.
And is the specific, so just acknowledging that this says subject to the safety protocols and visiting parameters in this framework. So it is subject to establishing the safety protocols and the visitation parameters later. Essentially what this recommendation would say is that there needs to be some way to say a resident can talk to their loved one and can interact with their loved one, understanding that there may be some scenarios that we'll talk about in C and D where it might be outdoors for a period of time or something like that. But at a baseline, there has to be some way for that contact to happen.
Um,
I'm just trying to understand if there's something here versus later on that we want to kind of lift up to edit.
So it's really, it's looking at the curtailing. So I think the important part is, as we're looking at what visitation is, there are people who are providing very necessary care. And so they should be considered as, you know, what we've decided here is this term. And so that needs to be factored in when we're making our decisions. But the part that it's the curtailing, the saying that you cannot curtail this for the following types under any circumstances. So whether, you know, maybe there's somebody asked me to give some examples, it's very difficult because I don't think any of us could have given the COVID example, you know, all the factors that went into that emergency. There were so many different ones, but say there is an Ebola outbreak. And so that is going to look really different than, say, a smallpox outbreak, or maybe there's a new type of flu. There's that type of outbreak. So I think that, you know, it's just, we don't know what we don't know. And so I think we need to have the tools in order to make the decisions that need to get made in this timely manner in order to protect the facility as a whole.
Okay, that's helpful. Thanks, Anissa. So it sounds like one of the areas that's troubling for you is actually the use of the term like not curtail, because that's a very broad term. Okay. Thank you. Appreciate that. Colleen, I see you have your hand raised.
Yes, thank you very much. And I want to support and concur with everything that Dr. Davis just represented. I'm from the California Health Executives Association of California, and completely support this recommendation with the exception of the added phrase at the end of the intro, for all the reasons that Dr. Davis just said. So my recommendation on the specific language would be that the newly added phrase at the beginning of the recommendation be eliminated. And to your question, Juliet, about the recommendations C and D and how those would factor in, some elements of those recommendations really require immediate response to come up with some alternatives or plans. And it's very hard, as Dr. Davis said, to really know in the moment whether there's going to be the ability to come together within 14 days and do these things. So it's very hard to predict. And by legislating or trying to legislate something that curtails our ability to be as responsive as possible while taking these principles and very important factors in mind, really, it makes it hard to know that we can be as responsive and protective of public health in any emergency in the future.
Thank you for that comment. Appreciate that. And we will get into that much more deeply when we get to C and D. So appreciate that comment. I think what I'm hearing from both you and Anissa is kind of a core edit in your mind that would need to be made here in order to be able to support or be comfortable with this recommendation. And I think you just said it pretty explicitly, Colleen, is to remove the term that says local and state orders not curtail, and instead perhaps clarify it with something like that they not prohibit long-term care visitation, acknowledging that there may be some parameters that get mentioned later, but that the core of it is that what this recommendation is intended to put forward is that orders shouldn't prohibit and entirely prevent visitation, understanding there may be some parameters.
I would say that language still sounds like it limits the orders in a way that that doesn't allow the health officer flexibility and the health department's flexibility to respond to any emergency. I would say something more like that, to the greatest extent possible, allows for visitors with these parameters.
Okay. Okay. All right, let's go to the next people line. Thank you, Colleen. Appreciate it. George.
Hi, thank you. One thing I wanted to get clarification, I think I understand this, but just to clarify, is when we say unlimited number of people who are designated as RDSPs, that's just the list itself. It's not saying that, essentially an unlimited number of people can visit like simultaneously. So I don't know if that's worthwhile to clarify at all, or if that is giving anybody heartburn. If that's not a source of confusion, then fine. I don't want to add anything further to it, but could be worthwhile to just kind of clarify that a little bit, so that there's no confusion that we're not talking about like an unlimited number of people coming at the same time to visit someone because they're all designated as RDSPs. It's just that the list of people can be unlimited.
Yeah, appreciate that clarification.
Thank you.
And I think definitely if that's an area that's causing any of the concern for folks, invite them to weigh in on that as well.
Yep.
Maitli, you raised your hand. And you have a related comment according to your chat, so perfect timing.
Yeah, George, thank you for the runway on that. So relatedly, in regard to A3, so the language is a little bit unclear in regard to what we mean by when there is a necessity to limit the number of resident designated support persons in the facility. Are we talking about per resident in that clause, or are we talking about per facility? Because that is, wildly different. There aren't actually enough of us to overrun a facility. It's very unrealistic. But I wanted to make sure it's clear in the language.
It is certainly intended to mean per resident. And we will add that if it is not already explicitly in there. I know it's gone through a couple iterations, so it may have gotten a little de-emphasized. So per resident is a key clarification. Thank you. Melody, you've raised your hand.
Hi, thank you. Yes, a couple things to note. And first thing, just as a side note, Mark, when Mark opened up and, thanking everyone for being here, and it's, for me anyway, it's been a privilege to be able to be on the panel and speak up. And I truly believe in this to the point I'm not getting paid to be here. And that isn't a comment on others far, but I take time off. Someone has to actually cover my work for me, who also believes in this project for me. And I know there's other on the call in the same situation. Anyway, having said that, I wanted to address a little bit regarding the topic of tools. And also that, we're still focusing a lot on COVID. And one thing that I had to mention yesterday, I was on the CalCTM call on infection prevention. And her name was Dr. Lily Hong, I think from DPH was on, and there was a lot regarding RSV and other things. So many times we relate back to COVID and what happened in the past. And what we're doing is preparing for what we might be looking at. Hopefully not, but very soon. And as another side note, I would recommend people going onto the CalTCM site and taking a look at that video, because being a non-medical person, I learned a tremendous amount from it. Anyway, regarding tools, I was involved or participated in a very interesting situation this past weekend. Friday, right after work, I happened to have checked Facebook, and among one of the caregiver groups I belong to, someone in Waymart, Pennsylvania, Eastern Pennsylvania, said, I got an email this afternoon that my mom's nursing home went on lockdown because they have a couple of COVID cases. And so we exchanged back and forth, got some information before the weekend was over. And of course, a lot of times changes aren't going to happen over the weekend because of who's in place. Across the country, calls were made from various states to the ombudsman in Pennsylvania, to the ombudsman supervisor in Pennsylvania. I was on the call with one of the supervisors at 6 o'clock here, which meant 6 till 7:30. So over 10 o'clock on their time, people reported in different states across the country to the Department of DPH in Pennsylvania. Calls were made to the facility. I know, like in most places, the facility staff were, very nice, very great to work with. And on Saturday morning, I spoke with the DON and we talked about the CMS regs and what was going on. And she said, because a lot of times when we're having this conversation, we're looking at the designated support persons, we're looking at the residents and so forth. And we certainly want to encompass and acknowledge the facilities themselves. And there's a lot of challenges that go on with that. So as we were talking, she said, well, what happened is we had some cases and we wanted to implement people wearing PPE coming in and people were refusing. So we just completely shut down. And I said, I understand that challenge that you had and so forth. And I said, but while we're talking on it, I want to encourage you to get involved in advocacy for laws and policies and protocols, because those policies and protocols would state that anyone coming in has to use the same PPE as staff. So that's something in their toolbox that they can stand on. Like right now, they don't have a law in place in Pennsylvania. And so they just had to say, hey, we're locking our doors. Where had there been a law, they would have that tool to stand on to say, you can come in. Nope, says right here, you can't if you're not willing to use PPE. So, that just became, really apparent of how much this means to everyone who's involved, to the entire treatment, to the entire support of the resident, as well as all of us, not only support persons, but the paid support, the facilities, that it means to everyone. And I also thought, right now we're going to be recommending to legislature, and what legislature is going to do with all of this information. I hope that something comes up very, very quickly, because between the conversation over the weekend, oh, by the way, the facility opened up first thing yesterday morning. So, in between all that, it became apparent of the tools that are needed, the things that we're putting in place with this work group. And if an outbreak and a lockdown happens again, and we don't have anything in place, first of all, yeah, the residents and the families aren't going to want to deal with it. Do the facilities want to deal with it? Does DPH want to deal with it? ombudsman. I recall talking to Mairead Painter, who's, national with ombudsman, and talking about how many calls they were getting from staff, from residents, and how much pressure it was on their staff. So if we can expedite getting laws in place, should something happen again with COVID, seeing an uptick on that, should something happen with RSV, does DPH want all those reports, the calls, the media attention, and not just calling out DPH, but staff went through a lot with that. I know they did. So in addition to what the families went through, I don't think those in the regulatory agencies and industry want to go through it either. So I know I'm getting on very much of a soapbox, but with the outcome of this and today being our last meeting, if there's any way possible of getting legislature to get systems in place ASAP, I think we all need that. Every single person on this call and everyone that we represent. So, thank you.
Thank you, Melody. Really appreciate that. Catherine, I see you've raised your hand.
I just wanted to do a little reminder about why we're here. The point of this, I believe, is to position the resident designated support person in the same position as staff who work in the facility. So just like we wouldn't curtail staff from going into a facility, a support person is in the same position and we shouldn't curtail them. So I think curtail is the correct word, because what we're trying to achieve is something different than what happened in COVID, when in fact, there were state orders that curtailed visitation. And so if we want to actually do what this group was charged with, I think we should leave it the same. I think we should make clear that these people are positioned, the support people are positioned the same as staff. And yes, of course, they have to use the same tools. They should have priority for those tools, for PPE and for vaccines and whatever else is available. And then my final note is, I hope we aren't in these discussions suggesting that using FaceTime is the same or that it achieves the same purpose. For some residents, such as my mom who lived in a long-term care facility, she was not, because of her disability, able to use FaceTime. It actually created more confusion, more upset, defeated the purpose of any attempt to visit her, because she 90 years old, had dementia, and couldn't understand what was even trying to be used as a tool to help her communicate. So thank you.
Thank you, Catherine. I appreciate that. Anissa, I see you've raised your hand, so we'll take that comment. And then I think if we can, we'll start to move on to the subsequent recommendations, because those details may actually help create more clarity on this one. Anissa?
Thank you. I was just going to, follow up on the last comment, that maybe that's what this should say, is that the recommendation is that these resident designated support care people should be treated as staff, because there could be times when some staff could be part of an order where there might have to be some kind of curtailing. It might say something like do telehealth if you can, or only the medical director can come in, or we're gonna not do this other type of thing right now. So I think that might more point to what it is you're trying to do, and not curtail the decision-making that health officers need. Thanks.
Anissa, Catherine, I really appreciate that comment. I would actually love some work group feedback on that one. So the proposal on the table, kind of based on this conversation we just had, which was really, really productive, I thought, was to come to a concept of, instead of stating that orders do not curtail visitation for the following visitor types, the recommendation would actually be to adjust the language here to create an equivalency between the access level of a resident designated support person and long-term care facility staff. So if we go to the next slide, we're actually going to ask people to respond to that. So in the chat, work group members are going, Caroline just dropped a poll everywhere survey into the chat. And we'd love, because we're in our last meeting, we're trying to really be as definitive as we can with some of these changes. We'd love to have people's initial reaction to that proposed edit, which would establish equivalency in the access level of a resident designated support person and a long-term care facility staff member. And we would edit the statement to reflect that. So please go to the link that Caroline just dropped in the chat and react to that. We'll give it a moment here, and I will try to be silent for a moment. I'm going to give it about 30 more seconds. If you need more time than that, please just let me know in the chat. All right. Based on these responses, we've got a very clear indication from the work group that we could move forward with this recommendation in the final report if we edit it to reflect specifically that we are tying access for resident designated support people to the same level of access as staff. So I just, first of all, want to thank everyone for that extremely productive conversation that brought us here. Really appreciate everyone's iteration and conversation to help us get to a recommendation that we can all jointly support, because that's really big and that's the whole purpose of this work group coming together. With that, and I do see the ask when we do the follow-up surveys like this to drop the language in the chat that we're recommending. We can do that for the next one. Oh. All right. And with that, we're going to open for a moment to public comments. Would love to hear from folks that have joined us today before we move into a conversation on recommendation B, to hear any questions or comments or reactions to the conversation so far. And let me go over, and we have Teresa has raised her hand. And you should be able to unmute yourself at this time, Teresa.
Can you hear me?
I can, yeah.
Yeah, I'm concerned that it be direct care staff. The same, it's got to be the same access as direct care staff.
Got it. Okay.
Thank you.
Appreciate that comment. Thank you, Teresa. Great. Any other comments from folks that have joined us from the public today? All right. With that, we will go into recommendation B. All right, so we did do a little bit of a reorder of the recommendations just for the flow of conversation. This next one is actually one we have not yet discussed in a meeting. It kind of came out of meeting 3 as a potential need, and we added it to the survey that we did between meetings. So we did send a preliminary recommendation that is intended to ensure access to emergency supplies for long-term care facility visitors, including support people. And just to on one note there, I'm going to pause there for a second. When we use the term visitors broadly, we're referring to any individual in the list that we looked at beforehand. So that includes ombudsmen, that includes any individuals that are not employed by the facility or living in the facility that come in, of which resident designated support person is a category. So as we look at some of the parameters that we'll talk about, they're intended to apply to both the broader category of visitors as well as resident designated support people specifically. And we call out if there's ever a situation where we're distinguishing one from the other when it comes to parameters of visitation. We provided an initial recommendation that would recommend prioritizing access to emergency supplies for long-term care facility visitors, including support people. And this, we received a first round of feedback from the work group on that via survey. So there was some just general confusion about why we may be in a situation of limited supply. And so we've endeavored to be a little bit more clear about when this recommendation would apply in the next slide. Some work group members noted that there may be times of extremely limited supply and just expressed concern about anything in the recommendation deprioritizing staff. And then some work group members indicated that there should be a requirement specifically for the supplies to be made available to visitors use. So not just that it be globally prioritized, but that then trickle its way down to the actual visitor. So if we go to the next slide, the proposed recommendation here does a couple things to address these pieces of feedback. So the first is we clarify that this recommendation is specifically applicable in a situation in which emergency supplies are limited across the board and in which state, county, and local authorities are involved in supply distribution. So this is very specifically speaking to a scenario like one that did happen in COVID and one that could happen in a future emergency where there's a type of PPE or a type of emergency supply, vaccination, for example, that is being distributed or in which the state, local, or county authorities are involved in the distribution of that supply. In those scenarios, this recommendation is one where the work group recommends that long-term care facility visitors, including support people, be considered among the top priority populations for any emergency supplies required to adhere to long-term care facility safety protocols. So just to thread an example through, if a specific type of mask is required of all people for entering a facility, this recommendation would state that visitors should be among the priority populations to access that type of mask, for example. Here we indicate when we say emergency supplies, examples include but are not limited to PPE, vaccination, testing equipment, that kind of thing. We did add the clause that the facilities shall provide emergency supplies to visitors, including support people, to the extent that those supplies have been made available to the facility by county or local authorities. And then we did explicitly note that nothing in this recommendation would deprioritize or inhibit access to supplies for staff. So I am going to open this up for conversation. And again, we'll use kind of the same process here. So what we're asking people to do here is really indicate, I have an edit to this that I would like this group to consider, or I have a particular issue with this recommendation that is a really significant sticky point that I would like this group to consider. And George, I see you've raised your hand. So let's start there.
Thank you. Would it be possible to I'm looking at B, so facilities shall provide emergency supplies to visitors, including RDSPs, to the extent that those supplies have been made available to the facility by state or local entities. Can we further clarify that this is also assuming that those supplies are actually available at the time of visitation is happening, because state or county can distribute supplies and then at some point they could be exhausted. So at some point they were given supplies, but then they're gone.
Got it.
So if they're gone and they're not available for anybody, then, you know, they may not be available at that time. I don't know if there's a way we can just kind of maybe make that a little more clear.
Great. I think we can incorporate that. That seems like a relatively small but important clarification. What I'm going to do, we won't take that to a full gut check for folks, but if anyone has a objection to that edit, please let us know in the chat and then we can talk that through.
Thank you very much.
Thank you. Appreciate that, George. Mark, you raise your hand.
Yeah, I
was just wondering how the equivalency standard that we set in the last recommendation kind of coincides with this. So it seems if we're putting resident designated support persons at the same level as staff at facilities, that they would have equal access to things like supplies and equipment. And just want to see if that's the direction we're headed. If we are, then I think that would argue in favor of, you know, and I know that facilities don't like the idea of creating lists of like designated visitors, but you know, the smaller the population, right, the more accessible things, supplies like PPE or vaccinations would be. So if that's the direction we're headed, I would probably recommend, you know, designating like, you know, limiting the number of, you know, called out designated support persons so that folks would have quick access to supplies. Otherwise, if you just open it up to everybody, that's basically the general population, right? And it might be hard to make visitors a priority population.
Great. Thank you for that comment, Mark. I'm going to invite, we'll kind of do like we did for the first recommendation. We'll invite folks to react to that, and then we'll pause and see if there's a particular edit we want to work on together. So I see Ken, you have your hand raised next, either for a comment unrelated to this or reacting to Mark's comment.
It's an additional comment, and it's one that may come up a little bit later, but you know, during COVID, a lot of people demonstrated the ability to be resourceful, and maybe this is a little too in the weeds, but is it reasonable to articulate something here that says if someone who is part, you know, an RDSP, if they themselves have the necessary PPE that meets the facility's standard and they're able to provide it for themselves, you know, would that should allow them to visit as structured, and I don't mean to be critical, but as structured, it kind of puts all the onus on the facility. But if people have their own and they're meeting the standard of the facility, that I think some recognition of that might be important so that the facility can't fall back and say, no, we don't have it, you know, you can't be here, or we're curtailing. That's my only comment.
Thank you, Ken. Appreciate that point. We do actually tackle that a little bit more explicitly in recommendation C and say that, but hear you that this as a standalone recommendation may create some confusion there. So we can either add kind of in the opening to the recommendation or in the recommendation itself, that cross-reference to recommendation C. Appreciate that. Nancy, you've raised your hand.
Hi, thanks so much, Juliet. I know we're just at the very beginning of this. We have a long way to go, so I'll make this as brief as possible. I'm just wondering if there's a way to consider maybe having PPE fall under the same like stocking. I don't know if there's like a specific stocking guideline for e-kits, but I think that PPE should have the same sort of guidelines as how an e-kit is stocked. And also, I just wanted to make a quick comment. We had an abundance of PPE here, but there were 2 facilities who were less than 20 miles away who had nothing for a long amount of time. And so we were able to provide them with the PPE that they needed and more. because at that time there were no visitors coming in. But anyway, so they ended up with an abundance. So once visitation started up again, people were able to still wear PPE at all of the neighboring facilities, including ours and the two that didn't have any to begin with. Thanks.
Thank you, Nancy. Appreciate that comment. I don't see anyone else with their hand raised. Oh, Karen, you've raised your hand. Oh, sorry, we'll come to you in just a moment, Karen, on the public. I do want to tackle a question head on in the chat first. I do see, Anissa, you've reacted to Mark's comment. I do just want to lift up the comment again for consideration. So I'll just reflect it back again now that we've gone through our list of folks that had their hand raised. So Mark raised the question that if we are establishing equivalency and access between a resident designated support person and staff, and here we are also recommending that resident designated support people be among the groups prioritized for access to PPE, might there be an advantage in being more specific about the number and the process for listing designees so that they can then get that priority? Invite people to weigh in on that one. Oh, we don't want to go to a survey on this one just yet. Thank you. Would like some comments on that. Anissa, you've raised your hand.
Yeah, I was just going to say the comment that I put in the chat. I didn't know if that's what you were looking for. But I do support what Mark is saying. I think that depending on what the situation is, again, and what kind of PPE is necessary, that there may need to be limits on the numbers. And the comment that I put in the chat was that it could be a fairness issue. If you have limited supplies and then you have really large groups of people for one resident and a really small group for another resident, that could impact who is getting this essential care in the facility.
Thanks, Anissa. Appreciate that. Curious if folks have any reaction to that. Beth, you've raised your hand.
Yes, let me turn on my camera. Thank you. I just thought of something. So with regard specifically to the vaccination part of it, and I'm sorry if this was brought up earlier and I missed it. So I was just looking at the list, and I know those are just examples, and I understand that. But a question is with the vaccine. So, for example, for COVID, when we had vaccines, were coming out and they were being available for different groups and et cetera. And then, of course, there were requirements and expectations associated with vaccinations. We had clinics in a lot of our locations. Some locations, I'm trying to think, we might have had one location that actually had the vaccine on site, but maybe I'm trying to remember, but because there was a time when we looked at them and we had to also look at storage and stuff. And basically what we did was bring in clinics. We partnered with Walgreens or whomever, and we had clinics on site. So my initial thought with regard to PPE testing, vaccines and things like that is that within reason, I do think that having them available to visitors is a good recommendation. I mean, we did do that ourselves, especially with PPE. Mm-hmm. We still are, actually. They're right there at the front door. But with the vaccine, of course, that was limited to the days that we had arranged for them to come on site. And so there wasn't a limitation in our experience in the agreement with those companies. There wasn't a limitation on amount. So presumably, yes, we could have made it available to additional people on site, but it was only on certain days. So I just thought I would throw that in there as something that maybe would be considered, that it's availability of these things or scheduling of shipments or scheduling of whatever that would make these things available versus less available to others.
Yeah, appreciate that, Beth. I think part of what we endeavored to do with this recommendation is speak to prioritization rather than the specific mechanisms through which one would be prioritized, acknowledging that different types of supplies have different, as you said, in some cases it'll be scheduling, in some cases it'll be actual supply, things like that.
Right. Okay.
Yeah. Thanks. Appreciate that. Karen, you've raised your hand.
Yeah, I just wanted to kind of bring a reminder back that we have an awful lot of I think it's easy to think visitor, even if we're using the RDSP definition, is extra and not necessary. I know that's what this whole conversation is about, is that they're necessary, but I really want to make sure we're reminding that a lot of these visitors are doing actual physical care. They're feeding people who cannot feed themselves, and the staff do not have enough time to really take the time that's necessary. And so we were seeing weight loss during the COVID pandemic because the family member who had been there every day, 3 and 4 times a day to give food, couldn't get in and was watching staff not be able to spend the time and kind of rushing through and taking away the food because there was a little pause, like, okay, they're done. Well, they weren't done. They just couldn't keep going and they were tired and needed a break. And I know it's not part of the recommendation, but I want to make sure we never get to a point where we're sort of putting a priority on people doing physical care, because the mental care is also important. That psychosocial side of it is so important for so many people. But I'm just really worried that we're going to get to a point where these recommendations may get changed a bit, and we're going to be back to PPE is only for the staff who work there. These visitors are not extra. They are completely essential. And we lost a lot of people during COVID that we didn't need to lose because they just didn't have access to the folks that they needed.
Thank you, Karen. I really appreciate that. And can I just ask you a follow-up on that? Does the kind of place we landed for recommendation A help advance that in your minds, creating that equivalency of access?
It does. I do like that one quite a bit. Thank you.
Great. Appreciate that. Thank you. Mark, you've raised your hand.
Yeah, I just want to respond to a comment that Karen had in the chat regarding facilities purchasing the PPE or carrying that as a cost burden. That wouldn't be I don't think that'd be the intention. During COVID, at least, a lot of those were state purchases, or they were provided by federal government. So yeah, I mean, this would be something that as the state or the federal government acquires these resources, then the resident designated support persons would be a priority population equivalent to a staff person.
Thanks, Mark. Appreciate that clarification. So there has been a conversation put on the table about, helping to ensure prioritization and access, helping to really make sure prioritization of access in the facility, access to PPE by having more specific lists of individuals totally at the resident's discretion who they are saying they want to visit them in a state of emergency in which there is a public health risk. I would love to get a sense from the group if there would be some comfort with having a designation to say, for example, a resident can designate 3 people at any given point in time. I'm putting the number out there, but I'm going to ask people to give me a number in a moment. At any point in time to be a resident designated support person. They can change their support people when changes happen in their life. That is natural and normal. But would there be comfort with saying that there is a number that people can designate? And if we can go to the next slide, let's actually go ahead and do a quick poll on that one to see how comfortable people would be with adding an element that would potentially say there is a number of individuals that can be designated as a resident designated support person. And I will drop that in the chat as well as folks are considering that. Okay. Seeing kind of a variety of stances here. All right. I'm wondering if anyone who has indicated that they would prefer not to make this edit and add this in would be willing to kind of share some thoughts on what their position is here and why they would not advise this addition. Karen, you raised your hand.
So as an ombudsman, I spend a lot of my time sort of dealing with family issues, and you get a lot of families that have factions. Or you get family who comes in, you know, once in a while, they're sharing the duty of doing care. So I see not a lot of people coming in at once, but a need for residents to have access to more than one or two people for a variety of reasons. And it would be particularly for the folks who have families who don't get along with each other. It would be a real shame if one side of that faction got access to mom or dad or the person in the facility, and the other side simply couldn't because all the spots had been used for visitation for that person. I would maybe say, and I don't like any visitation limitations, to be honest, but you know, it could be if they have more than, say, 2 people designated, then they would have maybe a limit on a number on the day. But I can tell you how much struggles the facilities had when people had to figure out who got to visit that day. I got a lot of calls from facilities when that was happening because the family person A was there and family person B also wanted to visit, and they couldn't be in the same room together. And then who gets to decide that? Is it the facility staff? We need them doing care, not trying to figure out family issues. So I think if you're limiting how many people, it's going to cause its own problems. And some people who really need to be able to visit with their loved one aren't going to be able to do that.
Thank you, Karen. Appreciate that. Catherine, I see you've raised your hand as well.
I will just add to what I thought were Karen's good points of the need for support is individual, right? Depending on the significance of the support needs. If you're primarily even just talking about feeding or assistance with toileting or changing, those kinds of things, that's going to depend on the individual. And one person or 2 people may not be able, given everything else that's going on in their life, to be the 2 designated support people. So it just seems as though you create more challenges by putting an arbitrary number on that may not meet the needs of that individual and may not appropriately accommodate the significance of their disability.
Thank you, Catherine. Appreciate that. Eric, you've raised your hand.
Yeah, I'd agree with what Karen and Catherine just said, and maybe ask or make an observation rather, that it seemed to me in following the conversation that this suggested edit came a little bit out of left field. It wasn't clear what the point of it is. If it's dealing with the shortage of supplies, this doesn't necessarily address the problem and prioritize things appropriately. And so I'd ask that if you could respond in just a couple of sentences, if that's possible. What's the point of this? Because to me, at least, it's not obvious how we move to this suggestion from the conversation that we were having.
Well, actually, I see Mark has raised his hand, so I'm wondering, Mark, if you want to chime in on this.
Yeah, I'm happy to clarify. So at the beginning of the pandemic, we know that PPE and vaccinations were in very scarce supply. So that being the case, and hospitals, facility staff were prioritized, we're trying to create this equivalency standard with visitors, which is good. But if you have a scarce supply and you only have X amount of vaccine and PPE to go around, who do you pick and choose to distribute that to? If you can't, like say there's, 50,000, whatever, people who are, visitors, and there's not enough supply to accommodate all of them, then what do you do?
Yeah, my response is it seems like a blunt instrument. It's for us not knowing the circumstances, setting a limit like that seems not responsive, as other people pointed out, not responsive to people's individual familial situations, their personal situations, and not necessarily the right prioritization as to whatever overall limits there may be in any case. So it risks a little bit going back to the problem that we're trying to address, right? That people are just told, no, sorry about that, we can't do anything for you because there's a guidance from several levels above us, and there's nothing we can do about it.
Thank you, Eric and Mark. Appreciate your comments. Catherine, you have your hand raised.
So I guess the question is whether particularly for PPE that even would address the problem. Because if I come as an individual, every single day I'm going to get PPE, unless you're suggesting that I just reuse it. And so is it any different if I go 7 days a week versus I go 3 days a week and my brother goes 4 days a week, right? It seems to me kind of the same amount of PPE absent the vaccine discussion. So I really am struggling to see how saying there's a limit on visitors is solving a mask, other kinds of shortage things.
Thank you, Catherine. George, you have your hand raised.
Thanks. I would say my suggestion would be, instead of maybe focusing on the visit, the number of, RDSPs per person, the group, maybe we focus more directly just on the PPE issue itself. Like, for example, I don't know what the solution is exactly, but we're talking about, on one hand, for example, the vaccinations. When we did have visitors coming in during COVID, the facilities didn't arrange for the family members to get vaccinated. They were getting those vaccinations on their own and then coming in. So, and I'm not saying I don't know what the solution is, but what it sounds like is we should focus then on the PPE, because that seems to be the problem, and not focus on changing the visitor aspect of it to try to solve the PPE issue.
Thank you, George. Appreciate it. Mark?
Yeah, and this is a great discussion, and I'm hoping to get towards a solution here. So what I'm hearing is folks aren't comfortable with setting a number of visitors, and I can appreciate that, or naming individuals. If we focus it on PPE, so given what supply and demand of PPE looks like at any given time, there will be a certain amount of PPE, say, available at facilities for RDSPs. And I'm not exactly sure how that gets prioritized, like first come, first serve. Whoever gets there first gets access to, to their loved ones. And this might be getting too into the weeds. I'm just trying to think practically when you have a time of scarcity, and we know that at the outset of COVID, we definitely had scarcity in terms of PPE and the vaccine. And the vaccine is another issue, and I'll let public health colleagues speak to those issues. Whether you allow people into facilities who are unvaccinated or not, but I'm just trying to address some practical considerations here, because I'd hate to put something forward in legislation and then have it collapse in practical terms when, if there's just not enough go around and there's not a prioritization scheme in place, what happens to RDSPs at that point?
Thank you, Mark. I appreciate that comment. It does make me wonder if we think about a provision in this recommendation that notes that in a situation of extremely limited supply, there would be some process for further prioritizing access, rather than necessarily revisiting the RDSP designation generally. Maybe that's a way to approach that. And I see Anissa has her hand raised. So Anissa.
Yeah, I was thinking something similar to what you just said. Like, I understand not wanting to have a limit on the number. So say somebody has 10 that they've listed. But if you don't have enough vaccinations, for instance, which there was like a finite limited number, then I feel like there should be something in here that signifies that just because there's that many on the list doesn't mean that all of those people necessarily are going to have access to PPE. Like they'll be prioritized, but it just might not be possible. And if somebody has 10 on their list and another person has 2 on their list, like how do you balance all of that? Like that to me is the issue.
Appreciate that, Anissa. And I think that's something we can add to your and Mark's point, something we can add into this element on prioritizing PPE that doesn't necessarily change the RDSP designation itself. And I just saw a hand that was raised go down. So I'm going to imagine we've maybe addressed the comment. I do know that we are running a little behind time. And it sounds like folks are generally okay with this recommendation. And can we go back to it for a moment? I just want to emphasize what it is again, because I feel we talked a lot about maybe there needing to be a need to prioritize, but I do want to emphasize that what this recommendation at its core does is it provides a recommendation to state, county, and local authorities that resident designated support people and other types of visitors that we identified in recommendation A, like the ombudsman, should be among the priority populations for supplies. I just want to emphasize that is kind of the core part of what this recommendation is doing. And it is stating that at the state and county and local level that they should be considered among those priority populations. And I'm hearing general agreement for that. I didn't hear anyone say, nope, let's not consider them among priority populations. So it seems like we can continue forward and then add a little bit of context around what happens around extremely limited supply when there needs to be deeper prioritization from the day-to-day of how things are rolling out. Okay, with that, I'm going to go to public comment for this section before we move into recommendation C. And so I do see that we have, Karen has raised her hand, and Karen, you should be allowed to unmute yourself.
Okay, am I unmuted? Can you hear me?
Yes, we can hear you.
So what I want to point out, and I don't know how it fits in here and how to be addressed, but during this time of testing and PPE, et cetera, assisted livings and RCFEs were not treated the same as skilled nursing facilities. We did not have, as visitors or essential caregivers or whatever you want to call us, did not have the same access to PPE and testing. The California Department of Health, along with where I live in Los Angeles, said at a certain time that they supplied PPE and tests to skilled nursing facilities for a long period of time. They were supplied when they could get it. And we did not get that. We did not have that. So we're not considered the same. I think that should be addressed. I was in contact with many people that when they went to visit their loved ones in a skilled nursing facility, they got PPE. They got tested before they got, and that was supplied by, I don't know, California Department of Health or CMS because they're federally funded. Assisted living, I would go and they had PPE, they had tests, but they didn't have to give it to us. They would say, no, we don't have to supply you because Department of Health, I mean, the California Department of Social Services had no such guideline or rule. So I would argue that if this what we're trying to propose includes assisted livings and RCFEs, that it should all be the same. And if it's being supplied, then it should be supplied for everyone.
Thank you, Karen. Appreciate that comment about the distinction between the facilities themselves as well. Thank you for that. Next, we have Teresa, and you should be able to unmute yourself at this time, Teresa.
Hi, I agree with Karen that DSS has to be the same as CDPH in terms of prioritization. I also think you should get rid of D, the paragraph with compassionate care, because that's where all the problems are. And I do think that if RDSPs are encouraged to select among themselves with the residents' help, who shouldn't visit, that's the highly individualized way of limiting RDSPs, and it should not come from above. A nursing administrator should not be able to select who can visit and who can't. The resident and the RDSP knows what they supply that the patient would not otherwise get. And it's very important that we maintain the equity between RDSPs and staff, and it's not stated strongly enough. Supplying sufficient PPE for RDSP should be part of the cost of doing business, whether the government covers it or the individual facilities cover it. If there's really equity between staff and RDSPs, that is part of the cost of doing business. Thank you.
Thank you, Teresa, and I appreciate you raising that point on compassionate care. We're actually going to have a more full conversation about compassionate care a little later in our meeting today, and can come back to this recommendation as we do that. All right, with that, I'm going to take us into our next recommendation because we're running a bit behind and hoping to get through everything today. So our next recommendation addresses the safety protocols that visitors, including RDSPs, must follow when visiting a long-term care facility. So this is a recommendation that has been circulated a couple times to the group already. We've done 3 different versions of it. We'll talk about the 3rd version today, but I do want to provide a bit of context and history on how we got to this recommendation. We looked at the first version of this recommendation in meeting number 3, and folks also provided some offline written comments about it as well in a follow-up survey. A lot of the feedback that we got from the work group is summarized here on this recommendation. So one of the pieces that we heard from you all is that really most of it really dealt with what to do in a non-standard situation. So this recommendation, as folks may recall, establishes a standard for visitation protocols, and then identifies a process through which anything that's not standard would have to be developed. The first piece of feedback we got on that non-standard process would be that should always be set at the state level, never the county and facility level. So if there's ever a scenario that would call for something unique that we maybe can't anticipate in a state of emergency, that would be applicable statewide. The second is that the initial recommendation to convene a stakeholder group within 30 days was considered far too long, and it was really unclear what would happen during that 30-day window. So we endeavored to be much more clear about what would happen in that window of time, and we've reduced the window of time to 14 days. We also got feedback from the work group that visitors, including RDSPs, may want to follow more stringent safety protocols, such as, for example, using a higher quality mask than those followed by staff. All of these were incorporated into the version number 2, if we go to the next slide, which was circulated via survey to the work group a couple weeks ago. The feedback in the survey is summarized here. So we did hear some concern about the feasibility of state departments convening a stakeholder group in a public meeting during a really acute phase of an emergency. So we'll talk about that today. We also heard some concern expressed about what happened during that 14-day window. And so what we heard kind of 2 different types of concern. There was, first of all, concern that no visitation would occur during that window of time. And then on kind of the other side of it, there was also concern that public health officials would not be able to implement any safety protocols or safety protocols known to be effective during that time. So we endeavored to be much more clear in the recommendations about what happens in that 14-day window. And then we also got some disagreement on what would constitute or what is meant by the term legitimate external factor. So we did remove that language and update it in the recommendation. So if we go to the next slide. This is the proposed update to recommendation C. So I'll highlight the core changes, which again are in orange, and then I'll give folks a moment to read it as well. So the first piece is we really highlight what is the scenario that we're talking about here in a scenario where safety protocols where long-term care facilities may be asked to implement safety protocols that are different from those of staff. So as a standard, this recommendation says that long-term care facilities should implement the same safety protocols for visitors and staff. It does identify that there may be unique circumstances of a state of emergency that may impact long-term care facility visitors' ability to follow the exact same protocol as staff. In those circumstances, state departments must issue visitor-specific protocols that would allow some form of visitation. So I want to highlight that edit to really emphasize that at no point does this recommendation say you can have no visitation. It says that state departments have to issue visitor-specific protocols. When they do so, within 14 days of issuing those protocols, they have to bring together a representative group of stakeholders in a public meeting to discuss those protocols, get feedback on those protocols. We list out what some external factors could be here that impact the ability to follow the same protocols as staff. And we really emphasize a couple core points here. One really big one is that nothing in this recommendation prohibits state departments from responding in a timely manner to legitimate public health or safety risk. It does, however, require consultation with stakeholders within 14 days of issuing any orders that establish visitor-specific protocols. The next is that nothing in this protocol would allow a full stop to visitation for any period of time. So I have now read through most of this, and I see Catherine, you have your hand raised. So Catherine, let's.
Thank you. I guess a question, because it says allow some form of visitation, and we just finished maybe in 2 prior sections ago saying that visitation could be by FaceTime or using technology. So if that's not what's anticipated, I think it's important to clarify that, because what happened during COVID is people would say you're allowed a visit because you can FaceTime with your loved one, even though that might not meet their needs, or you can do a window visit, even though that might not meet their need. And so I'm a little concerned that some form of visitation is too broad to accommodate what I thought you were saying, which is visitation, meaning you get to go into the facility with maybe some different kinds of PPE or something, not that we're now going backwards and saying it can be a window visit, for example.
Okay, appreciate that question, Catherine. Let's take a couple more comments and then we can maybe come up with some language. I unfortunately don't know the name, but someone has raised their hand as long-term care facility policy workgroup panelist. If you've raised your hand.
I'm so sorry. I forgot to rename myself when I got disconnected and logged back in. My apologies. This is Nancy Stevens.
Oh, hi, Nancy.
I'm a resident in long-term care, and I've been here for 5 years. And I think that these things should have been worked out. By now, we've lost so many people, and I think that resident designated support people should have top tier priority, the same as the same as staff or government officials or outside health agencies, those types of things, because no one was there to protect us. The last go around, I know this is not just about the last go around at all, and try not to focus on the last go around, but it's really hard when I lost 80% of my neighbors who I grew to love very much. And I think that also 14 days is just far too long to convene a public meeting with stakeholders and representatives and government officials mostly. I think that 14 days is far too long, and we should be much more of a priority. If the decision can be made so quickly if a decision can be made that a situation has arisen that it's so such an emergency that that they have to figure out how to get resident designated support people in, or if they're going to restrict or limit due to an emergency situation. If they can come up with that as quickly I think that this particular proposal or this piece of legislation or this policy should be an absolute priority.
Thank you,
That's all.
Nancy. Appreciate that very much. Thank you. Karen, I see you have your hand raised.
Hi, yeah, so I kind of feel like we're writing that policy. That's what this is, isn't it? So maybe we kind of look at rewriting this, and that if another visitor restriction is considered, either all these things that we're recommending become the new policy for visitation during a restricted time, or public health officials have 5 days to convene a work group if they want something else besides what we're all working so hard to create. I mean, we're writing it now. I don't know that it needs to be different than what we're writing right now. It just makes sense to say, use this when you're creating those differences or those limitations, or you only really get 5 days to figure it out, because to convene a public work group, as you guys well know, is not the easiest thing to do. And trying to come up with this process that you guys have done such a great job with is not easy to do. So why not just use what we're working on so hard?
And when you say what we're working on so hard, does that point to A in this essentially, or
Well,
are you
so far
suggesting
it's A and B. I'm just wondering if C just needs to be rewritten a little bit, just to say, use what we've done.
Thank you, Karen. Appreciate that comment. Anissa, I see you've raised your hand.
Yes, thank you. So yeah, I want to try to get clarity on this. So we're saying that we've designated RDSPs that we are going to treat as staff. So this particular instance is if we need to limit other visitation, right? So it's not that group.
Well, no, so actually, and maybe this is going to answer our whole question for us, because when this was written, A did not create that equivalency between resident designated support person and staff. So now that we have established that we're comfortable moving forward with that, having resident designated support person have equivalent access to the facility as staff, I guess maybe it's a question to this work group is, are we then comfortable with what is, I realize we should have numbered these a little differently, recommendation C part A without having part B? That's maybe the question to your point, Anissa, because perhaps if we're creating that equivalency at the beginning, I think the question to the group then is where might we need B? CB. No, we shouldn't have used all letters.
I'm a little lost, but carry on.
So here referring to, if the state for any reason determines the unique nature or conditions of the state of emergency may impact visitors' ability to follow the same safety protocols as staff. We have established earlier on that we are comfortable establishing equivalency between resident designated support people and staff. Are we then comfortable just saying visitors should not be subject to the same protocol, or long-term care facilities should implement the same safety protocols for visitors as staff in light of that, and just leaving it there?
I mean, there might be times when visitors absent RDSPs are limited.
So here we're talking about visitors. The capital V visitor is defined as RDSP.
Okay.
And then healthcare and social service staff not employed by the facility. And then the third category is visitors that have a statutory right to access the facility, such as ombudsman, patient advocates, surveyors, that type of category.
Okay, I think it would be good to call that out. I think it would be very difficult to convene a stakeholder meeting in the midst of emergency while you're making emergency recommendations. So I think if we are able to not have to do that would be best.
Okay. And would you then be comfortable saying, based on the visitor categories we've defined, we could just say they follow the same protocols as staff. Can we go back to those categories? Can we just look at recommendation A again to look at who we mean by visitors? Apologies if we give people a little vertigo here. Here we go. So this is who we mean by visitors. We mean resident designated support people. We mean individuals who have access to enter long-term care facilities through legal, statutory, regulatory, or similar authorities. And then we mean individuals who provide in-person services to residents, such as healthcare workers, hospice providers, paid caregivers not employed by the facility.
And then what we're saying for all of them is, again,
we're saying that, so the question is, would we be comfortable saying all of these individuals have the same access as staff and have to follow the same protocols as staff?
I feel like in concept, yes. I mean, I think, you know, you never know what you're going to have to do for an emergency. But I feel like in concept.
Okay. We'll mull that. If you have additional thoughts, we can come back to it. I do see Jack has his hand raised over there. Jack, can we go back to recommendation C, please, while we're doing that? Oh, maybe Jack no longer has a comment. I will go to Colleen then.
No, I'm sorry.
Oh, there you go. There you go.
No, my thoughts are, and I put it in the chat that less is more here, because I don't know if B clouds the issue, if there is already equity between. Because we're just giving.
It's hard to hear you.
Oh, I'm sorry. We're just giving them another opportunity. We're giving another opportunity to stall the process of letting visitors in by putting this, because the whole assumption that I'm working from is that this comes into play because of an emergency.
Mm-hmm.
So therefore, we already established equity, and maybe because we established equity earlier, where we didn't have that before, it makes B unnecessary in general, because the whole point of this is that we are creating, already established that this only comes into play, this whole new legislation, that there is an emergency. I mean, I'm a little bit confused too, having had the earlier discussions about the equity. So that's, just gonna put that out there.
Appreciate that comment, Jack. And this was definitely written without having had that foundation. So this likely needs some editing now that we have that foundation. So appreciate that comment. Colleen, you've raised your hand as well.
Yes, thank you. I see it as the equity conversation was about access. And so you're trying to carry that equity principle over to safety protocols as well. And I think that that I could support having a single phrase that says something about staff and visitors would have the same access and safety protocol, would follow the same access and safety protocols.
Great. Thank you, Colleen. Blanca, you've raised your hand.
Can you hear me?
Yes, we can hear you.
Can you hear me now? Okay.
Yeah, we can hear you.
So just wanted to lift up a couple of things. This has been, I wanted also just to thank, really appreciate hearing from public health and the executive association, because this is an important conversation to have. And one of the things I wanted to highlight is when I'm with the recommendation C, or excuse me, yes, the recommendation C, the safety protocols, even during COVID, it was imperative, and it currently is imperative, that all visitors and surveyors, ombudsmen, and everyone follow the same protocols as staff. And so the other thing I wanted to just highlight is during COVID, we had regular meetings at the state with our regulatory partners and other partners with Health and Human Services. And those were the times where we could really identify where the challenges were, what was going on. And so I would encourage us to stick to or ensure that there is some sort of this public facing meeting that would include key members of the different organizations, that what we're suggesting that they already convene even now, that there be part of the emergency management system, the OES, at the local level, and not wait until an emergency, but have those protocols in place now, so that when an emergency happens, there's already a forum and a group of individuals who are ready and prepared to address any of the issues that need to be addressed. So I don't know necessarily about the 14 calendar days. I think we do need to, at least for purposes of the statute, have some specific time upon which they should be meeting. But we found that extremely helpful at the state level. And it also helped us to determine where the hotspots were and what we needed to do in terms of prioritizing PPE.
Thank you, Blanca. Definitely appreciate that. It sounds like, I just want to make sure I'm capturing this right, that would be essentially a recommendation to keep in the report somewhere, a recommendation to have public, transparent, cross-department, cross-entity meetings. It's just not tied to this necessarily. Got it. That's really helpful. Thank you. Okay. And Eric, I see you've raised your hand.
Yeah, I'm going to ask a question again. I think that my thought would be that this is ambiguous as to what's intended. If you just look at the language, arguably it means that the state would be loosening the protocols for visitors in order to make sure there's visitation, given a shortage of PPE or vaccination. That's, I think, arguably reads like that. My sense from the conversation that it's something different is intended, that suggests that we wouldn't be modifying the protocols as much as we would be modifying folks' right to have access to the facility. So that's my question. What's the intent here in this provision, just putting the language aside for a second?
Well, I do think now that we have established earlier on that the work group is comfortable establishing equity in access, and it sounds like equity and safety protocols between staff and residents, we may not need this provision. The intent of this provision was to the kind of example that we were thinking of in our head as we drafted this was the example where vaccines are rolling out, and maybe there's a 3-week window where not all visitors have vaccination yet. And so maybe staff is increasingly going to be required to be vaccinated, or there's going to be some type of vaccine requirement that can't be enforced for residents. And so an alternate way to be able to enter the facility is made available to residents. That was the example we were gaming through. But I think what we're hearing now is comfort with saying that the protocols themselves can have parity and should be written for consideration both on the staff side and resident side of, a vaccine rolling out, for instance, and having multiple options for safety protocols for both staff and residents during that time.
Yeah, I think that when you read it now, I think I'm maybe repeating what you just said to a certain extent. it's contrary to what we've discussed for the last hour, saying that there should be general equivalence between the two populations. And then I'd suggest that if we regardless were to go through with some language like this, that it be clear that this is meant to be of assistance to visitors, just designated support person, as opposed to authorization to restrict their access to the facility. But again, I go back to your original point, which is that maybe you don't need this if they're treated equivalent. Then what's the point of suggesting what you do when they're not equivalent?
Exactly, yeah. And I think we'll do a pulse check in just a moment, but I see that George has his hand raised, so I want to give George a moment to provide his comments before we do that.
Hi. So I just going off of this, piggybacking off this conversation, I was legitimately actually confused then, because I was under the impression that this Part B was a mechanism to be more stringent or tighten up visitation for the designated person. So I think other people probably shared that confusion as well, based on the conversation we've been having for a while now. So I think either that this language has to get either clarified, or I think to some people's point, and I actually agree with it, if we're putting the designated support persons on parity with staff, and we're also making them a prioritized group in terms of access to PPE, et cetera, then this might not even be necessary.
Thank you, George. Appreciate it. I think we're hearing pretty clearly from the work group that we may not need what is section B of this recommendation. So I would like to take that to do a brief pulse check with people to make sure that reflects how people are feeling. If we go ahead and open up a new pulse check survey, would love for people to react, and we'll drop in the chat. My colleague Caroline will just drop in the chat what we're asking people to react to, which is, would you be comfortable moving forward without Part B of that recommendation, which is to say, saying that staff and visitors follow the same protocols. Colleen is raising a point that I'll just lift up and articulate about whether recommendation C is even needed if we've established parity and access at the beginning. We may merge the two in the final version, to your point.
I'm sorry, are we still discussing this point B to keep point section B as stated?
The question is, are we comfortable removing section B from this recommendation? So saying this recommendation simply says that visitors and staff follow the same protocols.
Yes, no, I'm sorry. Thank you.
No, I apologize. We didn't think about this when we use multiple lettering systems, and it's very confusing as I'm saying it out loud. All right, I'm seeing the numbers get pretty stable, so I think most folks have voted. Apologies, I shouldn't actually refer. This is a pulse check statement, and we'll be incorporating everything into our recommendation document. Okay. And most people have indicated their level of support for this, and it sounds like we can move forward with making this update to the recommendation. I want to thank everyone so much for how truly collaborative the last hour and a half, I'm losing track of time a little bit here, 2.5 hours have been. This has gone very well. We've actually made up a fair amount of time in the last recommendation because we were able to kind of work through some of the conversation by establishing that parity principle in recommendation A. So we're going to go ahead and take a 20-minute break at this moment in time. It is currently 2:35. So we will come back at, or sorry, it's not 2:35, it's 2:38. So we will go ahead and come back at 2:58. And I'll come back and kind of guide people to come back to their computers at that time. So thank you, everyone. Please take a 20-minute break and we'll see you back in 20 minutes. Finish your snack wherever you've walked off to, and please come back to your screens so that we can continue our conversation today. All right, I'm going to do a little bit of a recap of our conversation to date, and then we'll dive into the next recommendation. So we've talked through 3 core recommendations and made just tremendous progress as a group in a really collaborative discussion. And I just want to thank everyone for the conversation that we've had so far, and hoping we can carry forward this progress in our last couple hours here. Our first recommendation we talked through looked at the designation of visitors, and a really key point of alignment in the work group coming out of that first recommendation is that we would make an edit to the recommendation to state that resident designated support people have equivalent access to a long-term care facility as staff. So that concept of parity was established in recommendation A and was a really critical edit made to this work group that we're now carrying through in recommendations as we move forward. In recommendation B, the work group aligned around a recommendation to state that in any situation where state, county, or local authorities are directing and prioritizing emergency supplies in a state of any kind of strict limitation of supply, that long-term care facility visitors be considered a priority group to receive those supplies. And then finally, in recommendation C, we discussed safety protocols, where we really pulled through the concept of parity that we established in that first recommendation and aligned on a substantial edit to recommendation C to simply state that long-term care facility visitors, including resident designated support people, must follow the same safety protocol as long-term care facility staff. So those are our first 3 sets of recommendation. We've had a really great conversation to align on those 3 recommendations today. We're going to move into recommendation D. I am losing track of letters and numbers. I apologize. Recommendation D. And so in recommendation D, this is where we talk a little bit about any parameters to visitation that may need to be considered in a state of emergency where visitation is being curtailed or impacted in any way by that state of emergency. So we've already established that a resident designated support person has access to enter the facility akin to staff, and that they have to follow the same safety protocols as staff. Now we're going to talk about any additional parameters that may be permissible for visitation. So we've talked through a couple iterations of this with the work group. In version 1, a big piece of feedback we got was to be really clear that when we talk about visitation, we are talking about in-person visitation as the standard. We also talked through, again, we had a similar process in recommendation D as the one we just talked about, which was this ability, this process through which the state departments might establish a set of additional parameters to visitation and what it would look like for them to do that. So the recommendation from the work group is that if we were going to have that type of process, it had to be at the state level. And that the state departments would need to convene a stakeholder group much sooner than 30 days. So again, there was a recommendation to reduce to 14 days here. So we're going to take a look at all of that and think through how our alignment on parity maybe impacts anything in this recommendation, if at all. If we go to the next slide. We circulated an updated version of this to the work group, version 2. I'm not going to spend too long summarizing the feedback because I think we'll just talk through a lot of it in a moment. But some of the key pieces here again was concern with what happens in that 14-day window where the state is required to, where the state is convening a stakeholder work group. And there's kind of, again, here, there was concern that it would impede the ability to take effective safety measures to protect residents. And there was also concern that it would functionally lead to a situation where there was no visitation during that period of time. So if we go to the next slide, I'm taking us through quickly because I think we'll have a good conversation here and build on where we've been. So this recommendation talks about parameters. So we've established already in our recommendations that resident designated support people can visit on par with staff. They can access the facility on par with staff, and they must follow the same safety protocols. Here we're looking at a couple additional considerations that may be unique to visitors compared to staff. So one might be the locations in which they can be within the facility. The recommendation here is that we have a set of standards that are generally used for all of these parameters. And then in any situation where those parameters may not work at the state level, that state departments would establish specific parameters for that pandemic in consultation with a representative stakeholder group. The standards would state first that a long-term care facility visitor must be able to see residents in person in a location that is accessible for the resident and visitor as a standard. Generally, this should occur in a resident's room, although steps should be taken to ensure privacy in the case of a shared room. The second is that hours of visitation must be daily. And then this was an edit made based on kind of rounds of feedback we got from folks to say that it must be at least as expansive as those required of a long-term care facility outside of a state of emergency. Those requirements may vary by facility type. So this acknowledges that there is a current set of requirements around hours of visitation, and those would still apply in a state of emergency. All right. So I'm going to pause here and see if, I've lost my participant panel. Sorry, excuse me. This is what happens when we go on break. I lose my line. There we go. Okay, so I'm going to pause here and see if there are any immediate edits or recommended changes to this set of parameters. So this establishes baseline parameters that should be used in a state of emergency and says, if for whatever reason, this is not a possible set of parameters in a state of emergency, you have to convene a stakeholder group to have a conversation about the parameters you are using. Anissa, see you raise your hand.
So like the other recommendation, I think convening a stakeholder group before you make decisions or right after you make decisions, I think could be really difficult. It might be really unfeasible. And then as far as A1 here, that the location, let's see, that it should occur in a residence room, that may be challenged by the nature of the emergency. So I do feel like in general that should be the goal, but it could be that there's public health issues going on for the facility that may preclude that or preclude like the amount of people that might be able to congregate in the room or what have you. Thanks.
Appreciate that, Anissa. I think part of what we were endeavoring to do with the second part of the recommendation was acknowledge those situations may happen and set a way in which we could address those. But hearing you that there are challenges around that kind of rapid standing up of a work group in a time of pandemic or other state of emergency. I'm going to come back to this one in a bit, but definitely welcome any specific suggestions on a different way to approach that. Jack, I see you've raised your hand.
So the intent of this was if we ran into a situation where there was a need to limit visitation, right? So in simplest logic, we would say, okay, you can limit it for up to 14 days. What I'm not seeing in this, and I think that where I'm kind of concerned about the 14 days is what happens if you can't, reasonable or unreasonable, what happens if you can't convene something in 14 days? And you can't get a resolution within 14 days. I just don't want to put out, we don't want to have legislation that doesn't anticipate, that you can't promise something that you cannot for sure deliver. And what if you can't deliver it? What's the recourse? That's kind of my concern, because one, you've already you've already been established the authority to somewhat limit it for a short period of time. You've tried to put in a safety net so that something's happening during a short period of time. But the reality may be nothing gets decided within that window. Do we need more language or do we need less language? I mean, here's where we go again. I know we talked about arbitrary numbers for the PPEs and what is 14 calendar days versus 14 working days. So I'm just thinking, I don't know if you decide first. I flip it on its head. You have to decide first that you're going to limit it before you limit it, and then take 14 days to decide whether your decision is when you want to implement. But in the meantime, we've already created equity, so somebody's got to be going into the facilities. The staff are going in there, and if we're making the visitors equal to the staff, then as long as the staff are going in there, why can't the visitors continue to go in as usual during the emergency until something has been established that's been thought out? Because this is the other way around. You're going to allow all the staff to come in or keep coming in as they usually do, and then take 14 days to decide how you're going to limit everybody else while you're still limiting everybody else. I don't know if that helps you. I'm thinking out loud, actually, sorry, but that's kind of what I'm trying to do.
Yeah, so I think maybe just I can offer an example of what this might look like, what this might apply to, for example, and maybe we can pull that thread through. So a potential example, probably should have thought of one ahead of time, so I'm going to do one on the spot here, is that you may have a scenario where the airborne nature of a virus and the demonstrated effectiveness of PPE for that particular virus suggests visitation should happen in separate rooms. So like in the particular example of a shared room for residents, you may have a situation in a pandemic where you say visitation really shouldn't happen in a shared room. It should happen when the roommate is not there. We don't necessarily want to set that as the standard that you always have to have it without the roommate there, but there may be a situation where the State Department's public health officials are really advising that in this particular pandemic, there should be really strong measures taken to make sure that the roommate is not in the room, or if the roommate can't leave the room, that the visitation happens in a place outside the room where the roommate isn't going to be there, for example. in that particular case, if that's non-standard, that doesn't prevent the fact that visitation has to happen, but there may be a parameter that is unique to that state of emergency, and this would be the process through which that parameter would be set. But my example was not great just now. I see Karen's raised her hand. Maybe she'll have a better example. But that is what this is intended for. It's not to prevent visitation or to say it can't happen. It's to potentially say there might be a unique parameter in this pandemic that is needed, and what would be the process for that parameter. Does that help at all, Jack, or not really?
No, I think it, I mean, I think as long as it doesn't, because again, the more I thought about it at break, that was a very pivotal point when you equate the visitor, capital V, the RDSP with the staff. It kind of makes you think about all these other questions a little bit differently, because then the staff wouldn't necessarily be able to be congregating around somebody with they'd have to wear a special respiratory equipment for somebody with airborne. So that's kind of where I'm thinking. But yeah, no, you're right. I mean, your example got us close.
Thanks, Jack. I appreciate your comment and definitely hear your point about pulling that parity thread through and where does it take us. We'll go next in the line and see what Karen thinks. Karen?
Hi.
No pressure.
Yeah, no, I'll just fix the whole world. So I just wanted to remind that, a lot of the folks who needed those in-room visits during the pandemic had a roommate who couldn't leave or wouldn't leave.
Yeah.
And that means that person couldn't have a visit if the resident also couldn't leave the room. So anyone who was bedbound or it was incredibly hard to get out of bed was really missing their visitors more than, or their person, more so than even the residents who could get out and go to those common visiting rooms. And so it's really important to me that we do not let the location be the thing that stops someone from getting a visit, because I can tell you from an ombudsman perspective, roommate issues are huge. Do they want the TV on or not? Do they want the light on or not? And do they want to leave to allow the room to allow a roommate they may or may not like to have a visitor? And they're not doing it. And so that roommate's now making the decision of whether or not there can be a visitor. And again, really unfair, because folks who are bedbound need the most assistance from their family or from their visitors. So I really highly recommend not putting a limit on letting people have in-room visits, even during an emergency. The other thing that kind of occurred to me suddenly was maybe we should think about, when we're looking at this, we've talked about limited PPE. There's a lot of staff in care facilities who do not give any care. And maybe that's a place we can save PPE, is have them work somewhere where they don't need PPE away from the facility. Billing folks, they're not doing any care. A lot of admin folks, records folks don't need to be physically in the building using PPE. So that may be an option for using PPE for those designated visitors.
Thank you, Karen. Nancy, you've raised your hand.
I just think that if we're looking at resident designated support people having the same access as the staff are going in with the residents still in their rooms, if there's 2 in the room or 3 in the room or however many it may be. I just think that having the restriction there, having any restrictions there, goes against what we have already decided on as a group. That will have that resident designated support people will have the same access to their loved ones. And so, yeah, that's all.
Thank you, Nancy. Appreciate that. Tony?
Yeah, hi. How's it going? Just wanted to speak a little bit in support of the idea of the 14-day stakeholder group requirement. I've said a couple different times in these meetings that I think it's really important if we're going to have limits, any limits to what would be normal visitation and access, that there be some process that's sort of, that we all agree is a fair and quick process to get to the best decision in a very short period of time. And really what I'm thinking, when I read this requirement, I'm seeing like finally a step to not just for like good policy, but responsible policy making, to include the voices of the people that your policies are impacting the most. And this is something that was really dropped during, you know, the first 6 months to a year of COVID visitation restrictions. Is public health officers did not reach out to residents. They did not reach out to advocates, ombudsmen, and get their input. And I think the policies really suffered as a result of that, and felt less fair and deliberate as a result. I think 14 days is an eminently reasonable time, maybe too long of a time, for the policymakers to just seek the input of the people their policies are impacting. That's what I see this function here is to just get responsible input for your decision making.
Thank you, Tony. Appreciate that comment. We've heard some questions about this recommendation. I have not heard or some kind of general comments around how it fits into the broader framework we've talked about. I'm wondering if anyone has any particular edits they want to recommend to this at this stage. Anissa.
I don't really have an edit. I'm just not, I don't know how feasible it's going to be. And I understand this pandemic was very long. And there were a lot of moving pieces. So I don't know that if we would have been able, if the state was able to do a 14-day stakeholder meeting, how applicable that might have been, like 2 more weeks down the line, or a month, or 3 or 4 months, and once the vaccines got here and things like that. Like there were always, you know, so many different things. So I don't really have an edit. I just feel that it's going to be a heavy lift to have the state, every time they need to make a decision, to have to convene. I feel like it's like when we have to rapidly deal with these other emergencies, which are shorter, I do understand that, but you're kind of have to take the information you have and make a decision and kind of go from there. And so I do feel like it's difficult to do it, to convene all these things.
I think maybe one important clarification, and I'll ask if this helps, is this would only trigger the 14-day need, like that timeline, if for whatever reason the state wanted to issue an order saying that the parameters that are listed here around seeing them in person and around visitation being daily and equivalent in time frame is what it currently is. They would only, that 14-day clock would only start if for whatever reason the state said one of those 2 things couldn't be true for the resident designated support people that we've identified who are already following the same safety protocols as staff. Jack, I see you've raised your hand as well.
Yeah, I think that The way it's written now is, I think I agree that with a previous comment that it's nice to have the input. I can also see how practically there may be some challenges because you have to decide which stakeholders and how broad. I think where I'm struggling with is how broad that the policy may apply to such a broad area that there may be some differences between even the stakeholders. So there's that practicality, and then I guess the last part of it is that you know, I just don't want anybody to think that just because there's input that it always affects the outcome, and that's all this is saying, is that you'll get some input from some group of people within a certain time period. So really, there's no guarantee that any of that input will drive a different decision. And I think that that's where there may be some disappointment, but that's the reality. So that's just kind of where my thoughts are. But yeah, as it stands, it makes sense. If something has to be really out of the norm, that it becomes transparent as to why there's some sort of stakeholder group that can provide some input. I think that's what this is saying.
Yeah, it is really intended to focus on the transparency, the collaborative nature that you're getting input. That is the focus of this one, yes. Maybe part of the question for folks to consider is to just take a look at those two standard parameters that are listed here. And do we foresee a situation where those having established already parity in being able to enter the facility and parity in being able to do safety protocols, do we need to define these parameters for long-term care facility visitors, acknowledging that we've established that parity? And are there any situations in which we would foresee, with that parity in mind, these parameters might not always be possible? Karen, you've raised your hand. Maybe not to answer the question I've just asked, but that's fine.
Yeah, well, maybe it's close, but I think, I think Jack had a really good point that, input doesn't mean policy is going to be exactly what we want. And I think that's a good reminder also. But I think either there's a requirement that the plan, and I think Nancy pointed this out also, is created ahead of time with some minor room for adjustments so that we already know if flesh-eating bacteria breaks out in a bad way, or RSV, or whatever is going around, there's already a visitation plan in place to protect residents, folks, staff, the visitors, the public. So we've done it in advance, or we make it hard to destroy people's civil rights that normally takes a judge and a hearing and lots of attorneys to do. Most of us cannot, and I know it's normally a public health ability, but you shouldn't easily be able to take away people's civil rights. So let's keep it hard. If there's going to be this taking away of rights, even though it's for their own good, that's very paternalistic, and we don't want that to be a simple process. So I would prefer not to have any limitations, but if we have to have something, let's make it work right.
And Karen, just to clarify then, would this achieve that in your mind?
I think it would make people who can make easy decisions think harder about making the easy decisions. It is so easy to say, we just want to allow visitors. It is so easy to say, I've never met these people, but I'm going to make these decisions for them, and not think about all that they are and that their humanity is being affected. So I think this is a better option, but personally, I'd rather we have a plan ahead of time that is kind of bought off. We're doing a lot of that here, but let's make the actual plan. It's not that hard, and it's so much easier to make a plan when you're not in a crisis. And be the part of the legislation. You know, whatever the bill is going to be, let's make it part of the legislation so that the plan is already in place with just, again, minor changes. Is it transported by air? Is it out and about because of touch? You know, PPE kind of covers all that stuff. And some of the PPE really sucks, like face shields. Oh my goodness, but still barely getting COVID. So I think we could do it. This group is working really well, but if we can't come up with a plan as part of the legislation, then let's have a hearing. So people who make those decisions have to hear from the people being affected by it.
Great, thank you, Karen. Eric.
I'm going to suggest that the current language may be a bit ambiguous. In A, there's a discussion of standard parameters. And under that, it talks about where the visitation occurs and the hours of visitation. And if you go down to B3, it says nothing in this recommendation would allow a full stop. But arguably, if parameters just mean location and hours, that's the only thing that could be changed here. But because the word parameters itself, it just out of the dictionary is broader than that. B seems to just open up everything potentially, and I don't know, our conversation here may be contemplating that it would be broader than that, and the limiting parameters could be setting all sorts of limitations that maybe would go beyond where do you meet people and what are the hours in which you can access the facility. So I think it would help to have some real clarity there. If we're talking about location and hours, then we should say location and hours rather than tossing around the word parameter. Unless we define parameters as explicitly including only those two things.
Yeah.
But absent that, there should be some clarity here. Otherwise, it just throws the door wide open and maybe in a way that we're not intending.
Thanks for that comment, Eric. I think as written, it was certainly intended to speak to hours and location. If folks feel there are other things it should include, please let us know. But if not, I think we can make that refinement. Nancy, you raise your hand.
I put it in the comments, but I think this is really important, so I'm going to state it as well. I was wondering if we can change the words should. Like, for example, this should occur in a residence room. If we can change the word should to shall to make it more definitive and make it more of like a policy statement or something to actually abide by.
Okay, thanks. I think the one thing that came to mind as you were saying that to me is we wouldn't want it to limit visitation to the residence room, right?
Yes.
So yes, we might need to add a couple additional words there, but tracking that statement definitely. Thank you, Nancy.
Thanks. Thank you.
So I'm hearing generally that people are okay. And please raise your hand if what I'm saying you don't necessarily agree with. People are okay with this general framework of saying these are the standard rules per se for location and hours of visitation. If we're in a situation where we want to recommend where state departments want to implement different hours or different locations of visitation because of a legitimate public health risk, they would be required to convene a public group to discuss those parameters. And take input from a variety of stakeholder groups to have that collaborative policy decision-making that we were talking about earlier. Colleen, I see you've raised your hand.
Yes, are you talking about in advance of implementing any changes?
In this particular situation, we're saying what's stated here is that it would have to be within 14 days of implementing the changes. So it doesn't prevent timely response to a legitimate, fast-moving issue, but it does require consultation very, very quickly with stakeholders.
So I agree with Dr. Davis earlier that putting this requirement in the middle of everything else that's going on, especially if we've already talked about parity, I'm not sure. It's hard to predict what the emergency is going to be, but it would be. I don't think that I can support that as written.
Okay, thank you for that, Colleen. I see Casey, you've raised your hand as well.
Yeah, hi, this is Cassie Dunham from CDPH, and I just want to first qualify my statements that I can weigh in from the Center for Healthcare Quality perspective, but certainly cannot be presenting the department as a whole, because we have a number of other centers that in a major public health emergency, or even in a small public health emergency that affects limited groups of individuals, the response and the involved parties may be different, and those centers certainly would weigh in from a different perspective. Logistically, coordinating, I think, a stakeholder meeting, I'm certainly, from the CHCQ perspective, not opposed to something like that. But the logistics of bringing it all together and collecting input and trying to do that under the pressures, as I think Colleen and Anissa alluded to, may present its own challenges. And then the other thing that I would just encourage folks to be thinking about, that in situations like this where there's a need to make an emergent decision, sometimes there is a need for flexibility in the sense that we need to be planning also for the things that we would never expect to happen, right? My experience has been that what I can predict are typically not the circumstances that we face, it's the things that we didn't think about. So with that lens, being mindful that there may be limits on what we can accommodate under an emergency situation where critical decisions have to be made, life-saving decisions in a moment's notice. So, our full, intent of participating in this group is certainly to respect the rights of folks and make sure that the visitation is not taken away. We know that it had severe impacts, but I would also just say that let's avoid thinking of things in the perspective of either comparing them to COVID, because it's, COVID is, we've managed through that. Now expect what we're not going to expect, and circumstances being very, very different in another emergency. And then how do we facilitate decision-making around that? But yeah, I personally, from the CHCQ perspective, I think logistically pulling off a 14-day stakeholder meeting would just be difficult, not necessarily impossible.
Thank you, I appreciate that. Catherine.
I just note that it says consultation with stakeholders. I don't think there's anything that says it has to be a meeting, and having a process by which, if you're going to restrict something beyond what we understand to be the standards, why would you not in a 14-day period want to consult with stakeholders? I guess I'm confused by the assumption it's a meeting. I'm confused about why you couldn't come up with some creative ways to get stakeholder comments and hear the perspectives of people that, or their representatives that might be affected by the decision.
Thank you, Catherine. Waitley?
I guess I'm just confused. Are we talking about all visitors right now, not RDSPs? Because earlier in the session, we established that we all liked the concept of RDSPs being treated, given equal access as staff with equal, infection control protocols in place. So can you explain, is this just general everyone visitation other than RDSPs?
So this as written would apply to RDSPs. It was written before we aligned on that recommendation, though, that we would consider RDSPs as having equal access to staff. So it is certainly a question for this work group to answer is, do we need all of this recommendation if we've established that parity?
Yeah, thanks.
Yeah. Thanks, Bailey. George?
Thanks. Yeah, I was just going to actually say essentially the same thing. If we're pulling through the thread of RDSPs being on parity with staff, then I don't know why we need this, why we need at least B. I mean, if we want to clarify, hours have to be the same as they would otherwise be, I could see that A maybe is needed. I'm not sure we need B though. Just my 2 cents.
No, I appreciate that, George. I think that is a question for the work group, is if we've established this concept of parity, do we need one or either or any part of this recommendation? If we've already established that parity earlier. Catherine.
I guess the question for me is, do the entities that were concerned about getting stakeholder input in 14 days think that if we just leave it with parity, then that means there can't be any changes? Because the conversation has in both discussions said, well, what about Ebola? Or what about these other things? And I guess it leaves me wondering whether DPH or someone else believes that, fine, get rid of B, but we still have our other authority and we could do this and we don't need to consult with anybody. So that's the risk to me. Like, it's great to say there's parity and we can all agree with that, but then does that really mean there's parity and there won't be changes?
Thank you, Catherine. Waitley?
My comment applied to A and B, because A, if staff is going in at any hour that they're needed, and that's any hour of the 24/7 week, right? And they also are providing services in the privacy of the rooms, then why is this even a question now? Even section A.
Thank you, Waitley. George?
Yeah, I would just say facilities are legally allowed to have visitation hours. So just because staff is there 24/7, that's not always the case with, I come from RCFE world, so I can only speak in the RCFE world, but we are allowed to have established visitation hours, and they are not necessarily 24 hours. So just want to put that out there.
Thank you, George. Nancy?
I think that this policy makes that distinction between regular visitors or normal visitors to resident designated support people to have a different type of access. So it's not, I don't think this would fall under, facilities ability or right to have visitation hours per se. I think this whole policy is intended to make sure that there's a different category of people who can enter, not regular visitors. And then I also think that this is really unnecessary because it does leave too many loopholes for contradictions of previously stated policies or recommendations.
Thank you, Nancy. I think just one clarification on this one before we go to the next comment. When we use the term capital V visitors, that is intended to encompass resident designated support people. So just want to be clear on that, that as written right now, this would say visitation hours can adhere to the existing state of visitation hours for those individuals, essentially.
Can I make one more quick comment? My video is disabled, so I'm not able to smile or wave at you all. But I just wanted to say that, oh, thanks.
I was gonna say, on our end, we can fix that, I think. Yeah.
I just wanted to say that, oh, I lost my train of thought for a second. Go back to I think I might have put it in the chat. I know that the chat has gone over, but yeah. Oh, if staff have to care for a resident outside, like if there's a need, like a health need for a resident to be outside to be able to receive care from their nurses or nurse aides, then that should be the only time that a resident should be forced to either choose to have a resident designated support person in, or to go outside and have their RDSP.
Thank you, Nancy.
Thanks.
Maitli?
I just wanted to thank George because he makes a very good point. People residing in long-term care skilled facilities, they have 24/7 rights to visitation with people that they choose, their representatives, their family, people close to them. Our CFEs are living in the ice ages where we did not have such rights for people, and it makes very little sense. And this is a very important comment we need to make and also potentially fix right now by ensuring that inequity is squashed.
Thank you, Maitli. Jack?
Yeah, I'm just back to the, just want to reiterate the point, just to help us move forward, that as it's stated now, I don't see it as really restricting anybody's ability to visit because of the parity. If you were to take it all out, you still have the parity. I think Part A establishes to me that there's a minimum standard that must always be met. But again, because of the parity, if staff is there, then the RDSP can be there. I don't know what B is. I don't know what would be a legitimate operational safety consideration that wouldn't apply also to staff. Right? So it would have to apply to everybody, with or without B. So I think, yeah, I agree that it's not clearly defined what kind of input or how they could get it. But I think that this meeting is indicative of how transformational the pandemic was, and that a Zoom meeting like this can be convened relatively quickly. We're not asking people to get in their cars and drive up to a conference room. I don't know. I think this is one of those things that, if, in my mind, if you left it as is, or took it out, I don't think it is. It's not. It doesn't affect the overall policy. I'm just so focused on the fact that I think that was a game changer, the equity thing. If staff are going to be in there and an authority comes in and says, well, we're going to have to change some of these visitation issues, we could argue the room, where, and hours. I don't know how that it applies to the RDSP. It definitely applies to somebody that is a lowercase visitor, but not to the RDSP or the staff.
Thank you, Jack. Appreciate that. I think we're hearing, so I'm going to reflect back a few things. I think I have heard a few people comment that there is value in having a process for collaborative policy conversations. I think Blanca made that point when we were talking about the PATH recommendation as well. It doesn't have to be tied to what we're talking about here. It can be a broader recommendation of this work group that in situations like this, stakeholders should be talking to each other about visitation policies, and there should be ongoing collaborative policy conversations. So I'm hearing support for that and to keep that in broader recommendations, not necessarily tied to this ability to create non-standard policy, just a recommendation around ongoing collaboration. I think the core question then becomes here. I think one of the core ones I'm actually hearing get raised up a little bit here is about this question of hours. I will say we did survey folks around what hours of visitation people recommended, and there was a very wide divide in the group. The recommendation was to say that at least in a state of pandemic, you cannot restrict beyond what is currently available in a non-state of pandemic or non-state of emergency. I'm hearing some recommendation to potentially leverage these recommendations to be more expansive than that, but I'm not necessarily seeing, I think maybe I'll pose that and see if folks have any reactions to that or any additional comments they want to make to that on the hours of visitation and potentially providing a recommendation on what they would be that is this different than what is the current state outside of a state of recommendation, a state of emergency. Waitley?
I just want to share that during a COVID outbreak, my mom had C. diff and people were not going inside. They didn't have the booties and the other contact precautions available immediately. I ended up finding it on Amazon and I lived in her room for about 3 weeks, almost nonstop, 24/7. And so hours to me are a moot point and also a potential restriction that could harm someone. I'm really fortunate that I was in a place where I had some leverage. If I did not, like the majority of people, I don't know what would have happened to my mother because no one was going in there to change her. And I don't know if you know about C. diff, but it's constantly coming out. There's a very acidic diarrhea constantly coming out. It creates a major risk to the skin and infection and dehydration and just on and on and on. And if they're not going in or just staying with her consistently through that time, I don't know how she would have made it through. So I'm just telling you that there are situations that we have to consider that could be very harmful to a resident if we try to restrict to certain hours or locations.
Understood and appreciate that, Maitly. Mark, I see you've raised your hand.
Yeah, and sorry, my video is long, so I can't come on camera. But yeah, I mean, I think for the purpose of this work group, if we're saying that the resident support persons have, the same hours as they would standard, that would seem to be within the group. I hear, questions or concerns about RCFEs being on parity with, say, skilled nursing facilities and other facility types. That's beyond the scope of this work group. So that would be a separate discussion with other groups of stakeholders. So I don't think that's within this group to really discuss. But I think as written, if we talk about just standard visitation hours and having the equivalency with step, I mean, just like what the current standard is, I think we're fine.
Thank you, Mark. So that would be moving forward with the first part of this, but not the second part of this. And then noting in the report that there was a discussion about this for consideration around the hours, but acknowledging that it's from what I just heard you said, not necessarily in the scope of this work group to put forward recommendations for visitation outside of states of emergency. Is that right?
Correct.
Okay. Appreciate that, Mark. And I do just want to note, I know Mark went over this at the beginning, but there will be the final report on this. We'll have areas where we can elaborate on questions like this. And so that the areas that don't necessarily end up being words put into a recommendation can still be addressed and noted in the report as well. Any additional comments on this? So I am tracking, this would be keeping A and like keeping the first part of this recommendation and removing the second part of this recommendation. Ellen, you raised your hand.
Yeah, I would just say that there's an advantage to having the clarity and B around the 14-day work group that's coming together. So unless this detail makes it somewhere else, I would recommend keeping it in somewhere.
You mean the general recommendation around having a work group that
who is in it? You know, there's quite a bit of specificity as to who's in the group, why they're coming together. So maybe it's a standalone recommendation about that group. I don't think we're saying that that group doesn't need to meet because the two are equivalent, staff and visitors.
Got it. Thank you, Ellen. And so that would be a recommendation, still having a recommendation that is separate from this one around ongoing collaboration in a state of emergency with some specificity that's included here. Great. I think with that, we can go into the next recommendation. We can go to the next slide, please. Thank you. And before we go to that next recommendation, I am just going to take a moment to open to public comments around any public comments around the conversation we just had on hours and location of visitation. Teresa, you should be able to unmute yourself.
Yeah, anything that has 14 days in it at the expense of visitation is dangerous and should be jettisoned. And so I think B in this recommendation should just be abolished. I agree with Tony Chicotel that you want to have some kind of due process, but not at the expense of equity and visitation. Thank you.
Thanks, Teresa. And just to clarify, the consensus was to remove the second part of that recommendation, just to make sure everyone's tracking that piece too. All right. I'm referring to it as second part of the recommendation because there's so much lettering that it becomes confusing. This moves us into recommendation E. So this is actually a recommendation that was included in initial versions of these recommendations around having a specific recommendation that expands visitation parameters in the case of compassionate care. So we've made a few iterations on this one. One was to really elaborate on the situations that this would encompass, including to really emphasize that this is not a facility determination. However, we have had kind of a recurring theme of people not really being certain if we wanted to have this recommendation, and we wanted to have a compassionate care recommendation in the recommendations of this work group. So if we go to the next slide, from version 2 to version 3, We again got some questions about whether or not we needed this recommendation, and some feedback from some work group members to remove it. We also got some feedback on some refinements to a recommendation on compassionate care were the group to decide to keep it. If we could go to the next slide. The actual recommendation for compassionate care is listed here. I think the core thing I'm just going to highlight that this would do if the work group were to put this forward is essentially this recommendation recommends that visiting parameters, which is specifically to say the number of simultaneous visitors, which we've talked about, be expanded to enable compassionate care, as well as visiting hours. So we talked about the fact that there is the ability to say, in a state of emergency, a public health order could say that a facility can limit a individual resident to one visitor at a time, for instance. This recommendation might say, for example, in a state of compassionate care, you can't limit to one visitor at a time, or give a higher number or something to that effect. So that's sort of what this would do if we were to decide to move forward with it. But I think the gating question for this work group is going to be, does this work group want to put forward a recommendation related to compassionate care? And Melody, I see that you've raised your hand, so let's start with you.
Yeah, I'm just wondering, and I put in chat, I think we've talked about this a little bit before. It just seems extraneous to put at this point, particularly because we've got it covered in recommendation A, and then throughout the entire document of even professional outside caregivers and so forth. So I don't think this section is at all needed. It just is, it's redundant. So
thank you, Melody. Karen, I see you've raised your hand.
So the only reason I would say keep this is if we think there's a risk that any other recommendations will not be carried forward. So if we're going to lose anything else as the process goes through with the bill or with, eventual plans or whatever this turns into, we need to keep this. But if we think the other stuff is solid, like if we're not going to lose those things and our recommendations are really going to stand and become the new requirement in California, then this is extra, we don't need it. But we need it, we may need it as backup in case we lose the rest of what we've all discussed today. I've dealt with a lot of legislation, and sometimes you spend hours in meetings like this and then suddenly it's all different.
Thank you, Karen. Catherine?
I think I was persuaded by your points, Juliet, about the flexibility to have more than one visitor at a time, or some additional flexibility for someone who's at the end of their life, by way of example. And so I think at least the principle in particular, I think, is like important to acknowledge that even in a state of emergency, if you're saying only one visitor at a time, that there may be circumstances where that's not going to work for someone who is in these circumstances.
Thank you, Catherine. Maitli?
I agree that we should keep a clause that has this intention, because earlier we did potentially limit our DSPs per resident, right? And so if there is a great need that, that this calls upon, I think this would be a solution to that problem if it was during a time that they were restricted in number. But I do recommend, even though there is a CMS definition for compassionate care and established definition, everyone has adopted the connotation. And I think it would be a Herculean effort to re-educate everyone on what compassionate care would have truly entails. So I think that there does need to be sort of a more clarifying terminology.
Thank you,
because of the connotation, it has completely eclipsed the definition.
Yeah, I understand that. Thank you, Maitli. Nancy?
I can't remember what recommendation it was in. It'll take me a moment to find it, but I'll put that in the chat. But I was wondering if we could put maybe the term compassionate care under where like staff, administrators, public health officials would be able to have access to have compassionate care visitors on that list, so that RDSPs can have the same access using that type of language in that area of the recommendations, so that we don't have to try and define compassionate care later on.
Do you mean to just move in the recommendation that defines visitors, to move the definition of a compassionate care visitor there?
Yes, but also list the word compassionate care underneath where it says, like towards the beginning where it says that resident designated support persons will have the same access as staff and public health officials, ombudsman, on that type of list. I don't remember if we kept that in or not, but I think that compassionate care should be listed on that, so that there's no having to, make a distinction between who is a compassionate caregiver and who is a resident designated support person, because it's the same to me. Anyway.
Got it. Okay. Thank you, Nancy.
Thanks.
Any others who, I'd be curious if there's other folks that want to chime in on potentially not including a compassionate care recommendation. Ken.
Well, since you asked it, actually my feelings are quite the opposite. I think this should remain. It's intended to highlight an extraordinary circumstance. And I think Catherine Blakemore made a similar point along these lines, that if we're not calling it out, I guess I worry that it would get lost in terms of standard visit protocols. And I think I mean, let's be honest about what we're talking about here. And I do respect the point that some of the RDSPs are going to be the same people, but, for many of you have been there at a parent or a child's passing, and it's a much different dynamic. There's a lot of people coming forward that are going to take their last opportunity. So I'm at the risk of stating the obvious. This is an extraordinary circumstance, and I think it's really something that should be called out. Also echoing Karen Jones's point that there's always the risk of something getting diluted, and I think this was put in for a reason when we started. I think everyone was kind of behind it, and I think it's still a valid point to articulate. So thanks.
Thank you, Ken. Eric, you raised your hand.
Yeah, I'm a bit on this. I'm not sure where my vote is or where my pulse is on this. I think, but I recognize, I just want to point out that I do recognize the argument that it's redundant a bit. And in any case, I think it would benefit from some clarity in when you get to this point where compassionate care exception is warranted, because otherwise it feels a little bit like a wild card that opens up the system to some limitations that we have seen to prohibit a couple recommendations previous. So it doesn't seem consistent. I think if you track it, if you're trying to do a flow chart and say, okay, when is visitation for the designated support persons absolutely guaranteed, in this circumstance, but when is this exception that that the compassionate care becomes relevant. It's unclear to me how that flow chart sets up so that's why I don't think that's why I think it feels like there's an inconsistency between this and what we've done previously, which has seemed to have tried to lock down people's ability to visit no matter what. And so that would be my comment. I'm not voting or saying exactly what my position would be at this point, but my suggestion would be that if we were going to keep it, we'd want to, and I know this is hard at this stage of the game, but we'd want to have more clarity on that kind of flow chart issue about when would we be going down this route, and when would this route not be necessary, because of course under A, B, and C above, people just have a right to designate visitors who have a right and they have a right to accept in-person visitation from those folks.
Yeah, so I think just to clarify on, I think the main thing I would say for this recommendation, if it stands, is it does not change at all the right to resident designated support people in everyday moments. So that is the baseline. What we have acknowledged kind of in the lead up to this is there are potentially two limitations that may happen with a resident designated support person. The first is it may be permissible if needed in a state of emergency to say that you can limit the number of simultaneous resident designated support people to one. That doesn't at all change the number you can have over the course of a day. It's just the simultaneous that you have at the same moment in time. The second restriction we've identified is that current law does allow for some types of visitation hours outside of a state of emergency, regardless of a state of emergency. And while these recommendations are saying there should be no additional restrictions on hours in a state of emergency, that is still a general parameter. What this recommendation is saying is that we would go above. We would have more permissible access than limiting it to one simultaneous visitor, or potentially having limits to hours of visitation in a situation like this. It does not change the level of access that you would normally have. Jack, you've raised your hand.
I was just going to say basically the same thing. I think the whole point was to expand actually the options to visit, and beyond, we could even make it even stronger is it changed the should be expanded to must be expanded to a compassionate care. But I thought the intent of this was to expand the reasons for having visitation. And you could argue that lacking a designated visitor with a capital V, that you could argue this may be an opportunity for somebody that wasn't designated originally to come if a resident had some of the conditions that were outlined here. But yeah, I thought it was just to expand it.
Yeah, that's right. Mark, I see you've raised your hand.
Yeah, in addition to the two factors that you described, Julie, and I have had a third one, which is if there is a limitation in, PPE, vaccines, those types of resources, that compassionate care visitors may, get a higher priority, given the condition of the loved one. So that might be another reason for including this.
Thank you, Mark. Any additional comment before we move into our last recommendation? All right. I think with that, it sounds like there may be a little bit of wordsmithing and language changes, but that the general recommendation to say that those few restrictions that we identified that may occur for a resident designated support person would be expanded or lifted in a case of compassionate care. With that, let's go to the next slide. And we will pause again here for public comment before we move into our last recommendation. And Teresa, I see you've raised your hand and you should be able to unmute yourself.
Yeah, I think it's the compassionate care idea was so misused and abused. And my own mother was actually discriminated against because she wasn't quote unquote sick enough unquote to need compassionate care. And actually at the time she was, but the place was too understaffed for anyone to notice that she had stopped eating. I think what we have to do is jettison the limit on one visitor at a time. There has to be generous exceptions to that and individualized exceptions to that. And then we don't need compassionate care. Because the only thing that compassionate care makes a difference on is time of visitation and number of visits. And so if there are individualized exceptions to that, we don't need compassionate care, which is misunderstood and misused. And people, nursing homes were waiting till people were at death's door to let anyone in with this excuse. It was horrible. And who wants to go through that again? Thanks a lot.
Thank you, Teresa. All right. I think with that, it takes us into our last recommendation, which is a recommendation around a process for appeals and grievances in any situation where the resident designated support person's ability to visit a facility or the other types of visitors that we've identified is not honored. I'll acknowledge the first time the first time we walked through recommendations, we did not have this recommendation yet. We didn't get there, but we did circulate an initial version of a recommendation around this in the survey. So our version 2 of recommendations did include a recommendation around this. At a high level, I think one of the biggest areas of feedback that we got on the initial recommendation was to really emphasize the need for much more clarity on the timeframes and the process for appeals and grievances. So if we go to the next slide, let's just talk about the proposal before us and have a conversation. So there's 2 sections to this. The first has to do with clear communication of policies. The first section in that clear communication of policies speaks to clearly posting for that state licensing agencies will clearly post on their website the current policies for visitation in long-term care facilities, including required visitor safety protocols and any parameter that has been established via this framework. So I am just going to acknowledge right now, via all the verbal edits we've done today, we've eliminated that process for establishing visitor specific protocols and parameters. So we will make that edit here to reflect that here. I think that the comparable edit would then just be to say they need to clearly post on their website current policies for, both staff and visitor safety protocols and parameters for visitation in long-term care facilities. And those would be one and the same. The next is a note that facilities must then clearly post those policies in visible locations within the facility. And then the last is a call out that all of that communication must meet state accessibility standards, be written in plain language, and be available in threshold languages. So that has to do with the communication of these policies so that residents really have the information they need to say, this is what I have access to. The second part of this speaks to the implementation of those policies. This is a provision to really help ensure that they are implemented equitably and that residents, visitors, support people have the access to a grievance and appeals process that can address a situation where they may not have access to a facility, even though policies suggest they should. So here what we have suggested, acknowledging that this work group isn't necessarily going to sit down and write the extremely detailed P's and P's of exactly the ins and outs of a complaints process, where it would go on the website, et cetera. The recommendation here is that the work group that the legislature actually direct the state licensing agencies to develop a detailed process for grievances and appeals, and that those processes be released as a proposal for public comment prior to finalizing them. So that detailed work of determining exactly what an appeals process would look like for this, and whether it would build on an existing process or provide a net new process, would be developed by the state licensing agencies. That process has to include two core things that we call out here. So the first is it should include a method for a resident's loved one to appeal a situation in which a resident did not identify them as an RDSP, or a situation in which there is no representative able to make these designations. The second core thing it needs to include is a method for rapidly responding to a situation in which a resident designated support person was not able to visit a resident in accordance with the policies posted on the state licensing agency's website. So I'm going to open this up. Oh, and I skipped over it, but the policies also have to include specific timelines for responding to grievances and appeals. I'm going to open this one up. We have never discussed this recommendation in a meeting, so I'm going to open it up for initial comments from folks before we start to talk about specific edits. Catherine.
So just a clarifying question for me, are these intended to be regulations or policies in some other form? I think there's kind of pros and cons to both. Regulations take, we could be in the midst of a pandemic before a regulation would get approved, which means it wouldn't be all that useful. And so I guess I'm just trying to understand what form people are envisioning these taking.
I think we did not specify in drafting these, so I think we'll open it up to the work group to weigh in on that question. Do you have an initial, it sounds like your initial suggestion is it not take regulation, the form of regulation.
I guess there's a mechanism by which you can, I'd be interested in, I don't really have a recommendation, but in some other circumstances, there's a mechanism by which a department can do a directive until regulations are developed, with a timeline for developing regulations. I think that has worked okay, particularly if there's an opportunity for comment before the directive becomes effective. I just think, yeah, so anyway, I think there's pros and cons, and regulations take a really long time, like years.
Thank you, Catherine. Other comments or edits to this one? Maitli.
I'm sorry, I don't have an exact edit or comment exactly, but I would really love to hear public health authorities' response to this, especially in respect to how they would ensure that this information, because they would ultimately be behind the enforcement of this and, all that. And if I recall correctly, actually it's right in front of me, on page 2 of the Assembly Appropriations Analysis on AB 2546, the date being May 11th, 2022. On page 2, there is a fiscal effect in the analysis, and that refers, at that point, we did not get the CDPH potential cost analysis, but it looks like this is what the fiscal effect says. Estimated ongoing general funding costs in the range of $2 million to $2.5 million to CDSS for approximately 15 field staff positions to provide ongoing complaint investigation and enforcement of the new requirements. Additional one-time costs likely in the low hundreds of thousands of dollars to convene a work group, develop best practices, and develop regulations and provide a legislative report. I just wanted to bring this up, and this is why I would like to hear public health's response to that for a $2.5 million annual ongoing price tag. What in here, where does this, how are we going to address that? And is that real, that number? Thank you.
Thank you, Maitli.
So I'll respond to that. Mainly what you just read off sounds like it was the estimate, fiscal estimate from Department of Social Services, not CDPH. So public health can't speak to the fiscal assessment or the fiscal estimate for that projection. I will say that there would need to be consideration if you're setting a different standard from the typical complaint process. And if this were to be create a significant number of additional complaints or significant additional process, then there would typically be resources that would be needed in order to respond and to respond within a certain time frame. So I'll defer to our social services folks if they want to speak to the fiscal question.
This is Claire. I'm sorry, I realize my name isn't listed as TDSS. I can't speak to the individual numbers right at this meeting, but you're welcome to send that back to me. But just to what Cassie said and agree, yeah. So we will just have increased workload if we're receiving additional complaints. So we are generally asked if we do have to take on additional workload, like what is the resource needs to meet that additional workload. So that would be what's included. And then if there were ongoing work group or other obligations, those are additional workloads for staff. So happy to take a look at the fiscal estimate you're looking at and see whether or not it still connects in. You know, I'm not sure what it was linked to, so I can't speak to whether it's accurate based on what you guys are talking about right now. But I see that you dropped it and I'll take a look. But again, it seems like it's related just to a former proposal, so wouldn't be necessarily accurate for what you guys are discussing today. Thanks.
Thank you both, appreciate it. Tony, I see you raised your hand.
Thanks. I think maybe during the pandemic, I might have filed more appeals and grievances about visitation policies than anybody in the state. And just to share my experience was that generally, and most of them were nursing homes, the DPH complaint process, the typical DPH complaint process, and in my opinion, worked. And we didn't need anything special. In some of these cases, I did elevate things high, beyond the district offices to get something done quickly. But and I can't remember a case where I didn't get what I thought was a timely response, and illegal policies were amended usually within days of me having filed a complaint. So take that for what it's worth. That's just my experience. And then just one quibble on section A, subsection B, about facilities posting their policies. There's a little bit of irony here. If you can't get into the facility, that's the problem. How are you going to see the policy when it's inside the building? So I guess broaden the requirement to, sending it to email addresses or mailing addresses if the facility has them, and posting them to a website if the facility has a website, which a lot of facilities did during the pandemic.
Yeah, appreciate that, Tony. And I will say in practice, the policies that would get posted based on everything we've talked about today, the policies that would get posted at the facilities would be the same one on the licensing agency websites, because we've established that they would be the same now. So that might help a little bit there, but yeah.
I totally get that, but there may be some real tiny nuances, this is the person you call to know that you're going to visit, or this is how we would prefer you announce yourself, those kinds of things.
Yeah, appreciate that. Yeah, we can add that clarification. Catherine.
So I guess one solution to we're not going to figure out, I recognize that, kind of what form are these going to be in, but there should be a timeline by which the state licensing agencies are going to complete this work, right? And so I would encourage that we say within 6 months, or I'm making up a number, but it feels like there needs to be a timeline, and something that it'd be interesting to hear from Claire or others about sort of what's realistic. And then the process will include specific timelines for responding to grievances and appeals. I think there should be some expedited process. So like go back to our compassionate care discussion where a facility decides that, no, you can't have more visitors than what this restricted number is, like, and the person's going to die. So some expedited method within that appeals and grievance process for sort of responding to emergencies. So Tony's great because he knows how to get a quick response from somebody higher in the state. That is not most people's life and how they can influence how timely a decision is. So I just think sort of an exception for extraordinary circumstances would be helpful too.
Great. Thank you, Catherine. Heather.
Hey, thanks. I just wanted to follow up on the comment about facilities posting the information that they get from the state, what their policy is. I think the focus should be on communicating it to residents and families. There are a number of different ways providers did that during the pandemic and then just even on a regular basis. Sometimes it can be challenging to make changes to websites, especially if there is a major state of emergency. So just a caution, the ability of individual providers to make website changes quickly can be impacted during this time. But the focus is making sure that residents and families, the resident designated support persons know what the policies are.
Thank you, Heather. Appreciate that. Jack.
When we put this in there, I just understood this to be almost a canned statement that anytime you create new legislation and create a new burden, that you have to enforce it somehow, and there's always a grievance process. So I don't know. I mean, can you put something forth like a new law like this and not include some sort of grievance process? I mean, isn't it just part and parcel of anything like this, where you're going to stipulate that there are certain rights that we are maintaining for people, and if those rights are taken away, there's always going to have to be some sort of process. It just comes with it. It comes at a cost. I understand that, but you know, we're functioning at a $30 billion deficit. Right, tapped in the rainy day funds this year. You know, $2 million is a rounding error. I mean, I just think I just want to get us away from the idea that money has anything to do with it. We want to make good policy. We'll let Department of Finance figure out the, cost. But again, I just thought that do you have to have this language, or does it just happen automatically anyways? Because don't residents have a right, and their families have a right to some grievance process anyways?
Thank you for that point, Jack. I think folks should let me know if they feel otherwise, but I think folks are generally aligned around including a grievance and appeals process on this one. The question may be if there's additional elements that folks want to make sure we add in here, or any edits around what the process will be for establishing that. I'll just summarize a couple things. One piece that I'll highlight is we did stay silent here in whether it has to develop a new process or revise an existing process. That would be something for the licensing agency to put forward, whether it would be an existing process that's modified in X, Y, and Z way that creates a new category and it goes through that process, or it would need to be a net new. And that may help address some of the questions that we got around what the cost might look like, because you can imagine those are very different scenarios on that front. And then there is this element around putting it forward for public comment, so that there is the ability to weigh in on the timelines, et cetera, that are included in that process. Nancy, I see you've raised your hand.
Hi, yes, under A, B and C, I'm just wondering if it's possible to add, you know how, like elected officials, governors, even the president, Health and Human Services and CMS, they were all on television, talking about, you know, certain guidelines or regulations or policies that were implemented, in the last state of emergency. And I was wondering if there's any way to add like the letter D in there to add that elected officials, like state and federal elected officials, can also like make note of this policy during states of emergencies. I don't know. So people are notified. There was a lot of panic from inside. You know, a lot of residents were watching the news, not knowing what's going on, not knowing when they would ever see or receive help from their RDSP. So I don't know if there's any way to put that in there, that it should also be, the policy should also be included in
Communicated by state officials. Yeah.
Yeah.
Yeah. Got it. Okay.
Thanks.
Thank you. Any additional edits? Maitly.
I just want to clarify what I said earlier. This is a very important section, and I just don't think in 26 minutes it will be properly addressed, because I think the root cause is the rounding error, because, you know, and I mean, the root cause of, sorry, it's not the root cause, it's the root of these decisions do come from collaboration on a sort of like a more extensive level, you know, because it does include a lot of complicated things like money and resources and implementation and I don't know. I just that's what I meant. I didn't mean to say that it wasn't important, because it is absolutely important. I just think that I'm stuck in 25 minutes to even consider how I can contribute. I'm sorry.
No, I appreciate that point, Maitly, and I certainly understood your comment that way, which was not to say to not have an appeals and grievance process, but that the question of the how and the cost was important in what would end up happening. I think part of what we're endeavoring to do, and welcome your comments or other folks' comments, is to really say, to your point, it's not something that this work group is going to be able to sort out in 25 minutes. And it does require some pretty detailed, operational development of an appeals process that really best sits in the agencies that would implement them. So the recommendation here is actually to include in the law that the recommendation to the legislature would be to recommend that the legislature require them to put together an appeals process and gather comments on it.
In that case, can I add that the family caregivers and the resident stakeholders and advocates should be a part of that conversation as well?
Yeah.
Thank you.
Juliet, you're on mute.
I've just been talking to myself. Thank you. I was just saying we will clarify what's meant by public comment and speak to the collaboration element on getting input from stakeholders. Any additional comments on this one? All right. So I'm just going to summarize on this one. We are certainly acknowledging the importance of having an appeals process and a grievance process, and establishing that the recommendation to the legislature that the state licensing agencies for long-term care facilities put together a proposal for how that appeals process would work, that proposal would include timelines, that would include a process for appealing a situation in which someone was not designated as a support person and felt that they should be, and that it would include a process for rapidly responding to a situation in which a support person is not able to visit a resident in accordance with the policies we've discussed in this forum. That process, that proposal would be posted, made available for public comment, and opportunities would be provided for a representative group of stakeholders. Will pull from other language we've used there to weigh in and provide input and collaborate with the state licensing agency on that process. We'll also make the refinement in the communications around the policies to also note that
You're on mute again, Juliet.
I don't know why that keeps happening. Sorry. We would also include we would also edit the policies, the communication of policies section to note that the policies facilities must post them within the facility, and then must also have proactive methods for communicating them to loved ones and families of residents in their facility as well. And finally, I'll just note there was also the recommendation to establish a time frame in which the proposal around the grievances and appeals would be developed and issued. Mercedes, I see you've raised your hand.
Hi, yes, sorry, it was right before you started speaking.
No, go ahead.
Oh, I was just gonna say, yeah, a lot of us added some feedback that I think, you know, it's very useful. And so I was just wondering if you guys will look at that once or download that and take that into consideration. A lot of it is, you know, I did share some of my experiences, and I also wanted to add that I know, like, to me, it seems like we think of the worst case scenarios when it comes to visitors, like the potential threat, right? So for us who've experienced also the worst case scenarios of facility administrators being extremely restrictive, I have those experiences, and I'm coming from that place, and that's why I decided today to share that, because those things do happen. So if we're going to look at how we, family members can probably be very threatening, during a public health emergency, we need to also look at the other threats that came with that. So it's not that I don't have a bias against facilities at all, but I did go through my experience, and I wish I hadn't. I wish, the people who are in a position of power to make decisions would have handled things differently, but these are the realities. So yeah, so again, I didn't have a chance to share it out loud or voice it, but I did add a lot on the chat. So I hope you guys take that into account. Thanks.
Thank you, Mercedes. We definitely appreciate that. And we do store every chat and read it. It's also posted on the website for anyone else that would like to read it. But that's been a really invaluable source for us throughout this process, to read the transcripts of these conversations after the fact, as well as the chat. So please keep it coming in the chat. Todd, you raised your hand.
Yeah, I just had a thought around the 14-day kind of getting comment and convening a meeting or a work group. What would folks think of the idea of kind of naming a standing committee of interested community groups? Many of them, who are on this call to in the policy to say these are the initial people that we're going to go to begin that process of getting this group together.
Appreciate that comment. I will just make one clarification that based on the revisions made today verbally throughout the session, we have struck having that like 14-day requirement because we have struck the concept that non-standard protocols and parameters can be established because we set that parity.
Okay.
But we did speak to having a regular process absent that 14-day trigger, having a regular process for ongoing collaboration. So definitely hearing your recommendation that not be established when the emergency starts, but rather perhaps is a standing group called upon when needed. Is that what I'm hearing?
Yeah, yes, it is.
Yes, great. I know we're coming up near the end of our session, so I'll invite folks to chime in the chat. I'm already seeing some agreement there. So I think that makes great sense. Melody, you raised your hand.
Yeah, I just wanted to tap into what Todd was just saying, and I know that some of it was connected to the 14-day topic and so forth, but we've also had some broader conversations in here that after this meeting happens, there's some further work that needs to be done that would involve a broad spectrum of voices, and perhaps that work, developing some of the, whatever the legislature is going to be doing, adjusting some of the policies regarding grievances and so forth, that perhaps this roster can be resourced for some of those pieces of the work as well. So that's kind of what I was taking to from what Todd was saying. And I'm not quite sure if that was it, but just thinking, seeing we've already been part of the conversation. We are invested in what's going on. So that may be a suggestion to utilize this group for resources for those further conversations. Thank you.
Thank you both Melody and Todd for that comment. I'm seeing some agreement in the chat with that, so appreciate that. And Maitli, you raised your hand.
Yeah, I also appreciated Todd's idea because, Juliet, I might have missed it when you were reading the recommendations that you just compiled from today, but I didn't hear where the resident and family caregiver stakeholders would have direct input into those grievance policies before they're published for public comment.
Got it. Yes, I did not make that distinction about before public comment, so I'll add that in. All right. I think with that, we will go to our last opportunity for public comment for this forum. Realize we were just talking about a different type of public comment. If we could go to our last public comment slide. All right, and Teresa. Oh, no, apologies, Teresa. Karen is the first person in my line. So Karen, I will provide you the opportunity to speak. You should be able to unmute yourself.
Hi, okay, obviously these are just my thoughts, and I put them down before we discussed all this. So I originally helped work on the original bill, AB 2546, the Essential Caregivers Act. That bill was a decent bill in itself. It was supported strongly in the two committees it passed through, and there was no real financial burden attached to it. Then it got to the Appropriations Committee, and all of a sudden, of $2.5 million to enforce and regulate. We didn't expect that. My recollection is it was the CDSS CCLD that said that they didn't have the funding to police this Essential Caregivers Coalition. Part of the problem, I believe, is that they didn't have funding to take care of what they needed to in the first place. And we've had that issue. We've discussed that there has been problems with time it takes for complaints and grievances and appeals. I believe there were entities that just wanted to kill the bill, and that certainly did it. They never had to justify why it would cost that much money. They just said it. I'm pretty sure that's not true. There are not that many people that are essential caregivers or resident designated support people. We're not coming out in mass numbers and lining up at the doors of long-term facilities to cause such a mass financial burden, I don't believe. I hope that this time this can be thought out in a more rational manner. Okay, secondly, since I'm not going to be able to speak again, I want to be able to speak to the fact that I am my mother's voice. My mom is, my mom has dementia. She is in a long-term care facility. I am her voice. I am her ears and her eyes, and I'm essential. I am not a visitor. I would note that in all times, other than a public health emergency, I am allowed to visit my mom at a facility at all times, especially when she wants me. That is part of resident rights. Because a public health emergency overrides resident rights, something I would argue, but that is for another time. We need a law in place so residents have access to a designated person or persons for their emotional, physical, and psychosocial support. Before the pandemic and to this day, there have been problems in long-term care that became worse during the pandemic. There were violations, deficiencies, short staffing, neglect, and abuse. Facility staff, administrators, LA County Department of Health, California Department of Health, CDSS and CCLD and CMS were remiss in doing their job. Yes, I understand it's for a variety of reasons, but that is why this law is necessary. We can help, not hinder. Lastly, I'll say that I will not be locked out of my mother's facility, whether there's a law or not. Thank you for letting me say my piece.
Thank you, Karen. We appreciate you sharing that. Teresa, you should be able to unmute yourself.
Yeah, my experience with the previously very well-written AB 2546 was that it was subverted under the aegis of the cost by CDSS and CDPH, and this should not be allowed to happen again. And I recommend that there be another session of this work group. This has been a very positive experience for me, and I am someone that has absolutely no trust in this process due to what I and my mother went through in COVID. And I think it'd be a really good idea to have another session of this work group to really tighten things up. And that will limit the possibility of subversion of the legislation that we need to see. Thank you.
Thank you, Teresa. And I see Nancy, you've raised your hand if you'd like to provide a final comment for the work group today before we begin to wrap up.
Yeah, sort of to just repeat what Teresa said just now. I just want to say that I'm really thankful and so grateful, and so are so many other residents. About like maybe 35 that I talked to just this past weekend. They're so grateful that that a resident is allowed and invited and listened to, heard, and acknowledged on something as with great importance like this. So just thank you, and yeah, keep helping us. Thanks.
Thank you, Nancy. Melody?
This is Mark, because I know we're going to be wrapping up soon, and just a couple of little side things, because this is what I do. For anyone, who's on the call and so forth, then Karen, this would be a great thing for family councils and so forth, but I'm putting a link in chat. This is national, but LA County has a project called Project First Line. Anyone can register for it, and it is education on infection control. So, just kind of good things to have in someone's pocket, and maybe something that can be helpful for the resident designated support persons. The other thing, it is another link, and Nancy was mentioning earlier about residents not being informed, that maybe sometimes there was communication to the families, but the families couldn't communicate with the resident what was going on. And back in when COVID started, there was a group on Roosevelt Island in New York in a 500-bed facility, and there were about 200 of them there. And when New York was looking for places to put COVID patients, they were watching the news one night to find out that their facility, that no one was there, and their facility was being brought back online to bring in COVID patients. And their story is, well, I'm looking for a great word for it. Mapley, you probably can be, but I've gotten to know some of the individuals through some Zoom meetings and so forth. And PBS is doing a special, did a documentary on it called Fire Through Dry Grass. And it's coming out in October. So a little message for that, but I think it's something that everyone on this call would be interested in viewing. And, you know, reflecting on Nancy's sentiment, I'm really, you know, been thankful for this group and the process. And hopefully, as Terry said, there'll be further conversation. And just, I'm sure as you're wrapping up, you'll probably address this, but what happens next, what happens when the information goes to legislature, and then do we all just go our separate ways and forget we did all this work, or what happens? So I appreciate it. And Juliet, appreciate your the way that you facilitated the meetings and so forth.
Thank you, Melody. Thank you, everyone, for what was a really, I think, extremely productive, really collaborative conversation today. I'm going to hand it over to Brandi to provide us with some next steps and start our closeout. Brandi.
Thank you. And again, thank you to everyone, and especially to Juliet for navigating these meetings with so much grace and professionalism. You really did a wonderful job. So following today's meeting, CDA and MNAT teams will review additional feedback received by the work group and from the members of the public. As a reminder, the final recommendations report will summarize the discussion and the joint recommendations of this work group. That report will be submitted to the fiscal and appropriate policy committees of the legislature. Members of this work group will be provided a copy of the final report. If there are recommendations that your organization wishes to provide, but on which this work group did not reach consensus, work group members will have an opportunity to submit a letter or a position paper on behalf of their organizations for inclusion as an attachment to the report. And as always, materials will be listed on the Long-Term Care Facility Access Policy Workgroup webpage, which this team will drop into the chat now. Thank you again for participating in this important work. And before we conclude, we would like to have a word from our director, Susan DeMorris.
Thank you very much, Brandi, and hello, everyone. It's been a pleasure to join you for the tail end of this fourth and final meeting. I just wanted to take a minute to thank every single work group member, all who are present today, and if anybody's missing, for the hours that you've given to this effort, for your respectful debate and your collaboration, your diverse perspectives, and the expertise and experience that you've all shared, especially our resident members and our family members. Thank you very much for your contributions to this work group and to the report that will be developed as from your work. I also wanted to thank, of course, our legislative partners and the governor who made this possible, that we could convene this group and focus on this topic over the past 6 months. I want to especially thank the CDA team for their leadership, Brandi, Mark Beckley, our long-term care ombudsman, Blanca Castro, and all of our colleagues across government, public health, Department of Social Services, Department of Healthcare Services, who've made this a priority to participate. And then today I was able to hear public comment, but for all members of the public who've commented over all 4 meetings and who will follow up with comments after today's meeting, I want to thank you for your ongoing engagement and your participation in these conversations. And I'll just uplift Brandi's thanks for Juliet and the MNAT team. They've been terrific partners, and this is where I'm especially grateful to the legislature and the governor for providing the resources to facilitate such a forum
in such a professional way, so that we can all move forward and move to recommendations that we can all make good use of. So my thanks to all of you, every one of you, and especially you, Brandi. I'll turn it back to you.
Okay, well, thank you. Questions or comments? Email us. Someone will drop that into the chat. And that's it, everybody. Have a great evening. Much appreciated. Bye.